There's a lot
We're
of participants.
we're
Holy
good to
moly.
go.
Okay.
Awesome. I will reclaim host now that the YouTube Live has started. And we can get going. So yeah, hello everybody. Thank you for joining the second venous congestion webinar, which will be primarily focused on venous congestion and Ehlers-Danlos syndrome, or EDS, as we will refer to it hereafter. We wanted to host a webinar with an EDS focus due to the unique connective tissue challenges that EDS patients face, and since they can intersect with the development of and treatment for venous congestion. So my name is Julia Denley. I'm one of your co-hosts, and also hosting is Janelle Macklin. Janelle and I are both patients living with cerebral venous congestion, as well as many of the common comorbidities seen in patients like us. So we have HEDS, POTS, MCAS, and many others. We really appreciate you all attending and bringing attention to this issue. So thank you for being here today. I also just wanted to briefly address the fact that you aren't seeing me on camera. So folks may remember from last time that my intracranial pressure issues and CCI mean that I have to be flat. So we're really lucky to have a fantastic team of physicians joining us today. So please welcome Dr. Ferdinand Huey, our co-host for the webinar, who is the Chief of Neurointerventional Surgery Division at the Queens Medical Center in Honolulu, Hawaii. He's the chair of the section for venous and CSF disorders at the Society of Neurointerventional Surgery. And then for our other panelists, Dr. Paolo Bolognese. So in 2014, Dr. Bolognese established the Chiari Neurosurgical Center, which later became the Chiari EDS Center. He serves on the board of directors of the American Syringomyelia and Chiari Alliance Project, is a member of the Scientific Education and Advisory Board of the Chiari Syringomyelia Foundation, and participates in the International Consortium on EDS, HSD, and related disorders. Dr. Eileen Ruhoy, a board-certified neurologist who also has a PhD in environmental toxicology. She serves as the medical director for the Chiari EDS Center in New York and is the chair of the neurology working group for the EDS Society. Unfortunately, not able to join us today was Dr. Kyle Farjan, so I apologize for that. I know that will be a disappointment to folks, but he unfortunately had something come up, and we do still have a really fantastic panel of physicians here. Joining us later tonight will be Dr. Yoonhee Cha, an associate professor in the Department of Neurology at the University of Minnesota, where she started a clinical program using non-invasive vascular imaging to study and treat vestibular syndromes associated with venous congestion. She looks holistically at how musculoskeletal disorders impact the venous system and downstream alteration of neurological function. And yeah, she has an obligation for the beginning chunk of the webinar, but we're keen to include her experience, so hopefully she can join us near the end. Also joining us is Dr. David Kaufman, co-founder of the Center for Complex Diseases, which focuses on patients suffering from ME/CFS, dysautonomia, mast cell activation syndrome, autoimmune diseases, EDS, and chronic infectious diseases, including tick-borne diseases and small intestine bacterial overgrowth syndromes. He's a member of the ME/CFS Collaborative Research Center at the Stanford University Genome Technology Center and an active participant in several national clinician networks that focus on ME/CFS, mast cell activation syndrome, and autoimmune disease. Also is Dr. Peter Costantino, an innovator and leader in his field of cranial-based surgery and craniofacial reconstruction. He's dual board certified in otolaryngology, head and neck surgery, and in facial plastic and reconstructive surgery, and has been the founder and executive director of the New York Head and Neck Institute since 2007. And last but not least, Dr. Larry Lowe, a nationally recognized neurosurgeon who serves as the director of spine tumor surgery at Northwell and is co-director of spinal deformity surgery at North Shore University Hospital. He's a complex spine specialist with special emphasis on spine tumors, spine deformity, craniocervical junction abnormalities, and spinal vascular disorders. And as well, I just want to thank our organizing committee of patients. So we have them here today monitoring the Q&A, including Austin, Michael, Tiffany, and Ali.
Thank you all for joining us. We're so excited to have you here. We're going to have Dr. Huey give a brief presentation, followed by a presentation from Dr. Constantino about the work he and Dr. Lowe's team is doing with jugular decompressions at Northwell. After that, we will follow up with a structured Q&A with our panelists based on questions that we chose from surveying the patient community. We apologize if your question isn't answered or asked We received hundreds of questions and won't be able to get to everything, but we have done our best to prioritize the most frequently asked questions. We also gave the community a chance to let us know what topics they wanted to hear about the most. Based on those results, we will be prioritizing discussions around cerebral venous congestion and intracranial hypertension, with some time spent on CCI and CSF leaks. We'll also briefly touch on thoracic and abdominal vascular compressions, but we'll save the more in-depth analysis of that topic for a future webinar focused on venous congestion outside of the neck and head. After the structured questions, and if time permits, we will have questions from the viewers, which include the many physicians we have here attending today. Many thanks to any medical providers who are in the audience, as it is so important to spread awareness about venous congestion in the broader medical community. Some basic housekeeping things to go over before the webinar. Just a reminder that this webinar is for informational purposes only, and it doesn't constitute as medical advice. Any medical decisions should be made in consultation with a qualified healthcare professional familiar with your individual case. The chat function will be turned off for attendees during the webinar, so the Q&A, which you can find at the bottom of the Zoom window, will be your place to interact with us. The host will use the chat to share the questions being directed to the panelists for the sake of clarity as we move through the panel discussion. We will have volunteers monitoring the Q&A during the webinar, so feel free to submit questions there, and we'll save them for the end. You can also upvote questions submitted by other people, which should also help us determine which questions are most important to the viewers today, if we do have time to get to all the audience questions. To note, we have well over 800 individuals registered from all over the world for this webinar, over 100% increase in registrations from our previous webinar, which is super exciting. With that, our Zoom license only accommodates up to 500 participants. So anyone joining after the 500th participant will be directed to YouTube. If you're watching this on YouTube, then just know we'll do our best to keep an eye on questions being asked in the comments over there as well. So without further ado, Dr. Huey, we'd like to invite you to give your presentation now, and you should have screen sharing permissions.
Is that a sign for me to go? I apologize.
Yes.
I need to tell them that you know, the joke in my field with the other endovascularists is our day jobs are crazy and our night jobs is crazy too. I'm currently in between strokes. We have 3 right now. So give me 1 second to tell the team that the next stroke is a go, and I will be starting a new stroke. It's a go. See you soon. All right. First, I just want to tell you I love you. I know that sounds weird, but we really do. The doctors here, online or not online, we wouldn't be doing this if we didn't love you. You know you're difficult, and not in a bad way. It's just you have a rare disease. It makes it very hard for anybody to know what to do with you. Not your fault. It's just what it is. So this is a philosophical discussion, reflections over the last 10 years, 15 years of working with you all. I suspect my colleagues here will echo these feelings. So first, I want to give a shout out to the organizers living with these diseases, living with the brain fog, living with chronic pain, and still being able to pull off 800 people in a webinar, organizing a bunch of crazy cats for doctors to actually show up at the same time. This is Olympic level work, and they've done it amazingly. So silently give a hand to our organizers. You guys are amazing. My comments are really philosophical. I don't have a rare disease. At least I don't think I have one. I have had cancer, so I've been a patient, and that was an unusual cancer, but it wasn't what you're dealing with. People know what I had. We don't really know exactly what you have. As Paulo has been working with patients with EDS for years, EDS is not solved. EDS is not well understood. EDS is still something we're learning new things about every year. And I know Eileen has learned a lot about variations of EDS that don't meet what's in the books. And most of you are living with versions of EDS that certainly aren't in the books. So how do you go about life when you have a rare disease? Disclosures, I'm sorry. I'm going to skip this. All diseases have mechanisms. This is true. We just don't understand most of them, and we certainly don't understand yours. I will say that, and again, I think I speak for all of us, we have learned from you. If you did not tell us honestly what you were experiencing, we would have no chance of being able to help you. One of the most humbling things about being a doctor in this space is that we are learning constantly from your experiences. If you don't tell us that you have this cranial nerve issue, this sense of being disembodied, this sound in your ear, the change in your vision, we would have no chance at helping. Our first job in this space in rare diseases is to listen. I've had patients tell me that they have a mutation in X locus of X chromosome with these number of base pairs altered. And you look it up, there's no data. The only guide we have is you telling us that you've these experiences, and we cross our eyes, we make notes on our little notepads, and we think about it. But without your collaboration, without your partnership, this is impossible. And so in the absence of mechanisms, all we have is each other. Stories drive us. For me, one of the things that pushed me into committing to 10 years of research in this space was a suicidal patient, because we told her we had nothing left to give her. We did everything that we knew of. We stented her, we did surgery, we gave her a shunt. We said we had nothing left, and she killed herself. She left us 2 months later, leaving behind children and a partner. This is why we care, because we know the suffering is real. We may not understand it, but we do our best to stand with you and listen. So these are the challenges that I see as an outsider. You have symptoms. The healthcare professionals that you see have limited experience. How do you find the right practitioner? How do you find support groups? How do you manage risk? How do you move your data around? How do you keep your information straight when you have brain fog? So I'm just going to go through this really quickly, and then we're going to launch in the webinar. Don't let anybody gaslight you about your symptoms. What you experience is real. Yes, some of us get impatient. Yes, some of us wish you didn't have those symptoms. But at least the panelists in this room, we listen. We really do. We may not listen perfectly. We may be tired. We may be grumpy. But we're here because we believe you. Second, don't get angry at your other doctors. It's not their fault. They don't know what's going on. Most of us that go into medicine are trained from books, and the books don't include everything. And if you have a Ferrari of a disease, a Bentley of a disease, don't expect the Ford dealer to know what to do with it. Not to say that we are Bentleys and Ferraris, but it's not rational for us to expect most healthcare practitioners to know what a very special disease is. It's not been described. We're doing our best in this room to write more of this up, but we recognize it's frustrating. We recognize it's hard. Try to have patience with the doctors that can't help you. I'm glad you guys found this webinar. Support groups are everything. You guys share your experiences, and that's where you learn from each other. And frankly, that's where we learn from you. It's through surveys, it's through discussion that we as healthcare practitioners learn about the things you go through with. This is probably the most complicated one, managing risk. I'm going to tell you, all of us want to help, and sometimes we're going to do things that are risky or propose risky procedures for you. And all I can tell you is hope is dangerous. Hope is essential, but hope is dangerous. when you are saying yes to something that's dangerous because you have hope, it could either be a jump off a cliff or a jump into an airplane to catch you. And I can't tell you which it is. And so it's so important for you to always look at how miserable you are and the probability of success or disaster on the other side. It's individual. I can't tell you what you to do, but please, please, please be careful with your life. Your life is precious. And so we do not want you to come to harm for something that can't work or is unlikely to work. So I tell my patients, and I'm telling you, balance how miserable you are, how close to not functional you are to the thing that you're considering treating. And when you're at 90% good, throwing away 90% good for 10% more may not be a good choice. So be careful with each surgery you consider, with each drug you consider. We are working towards better movement of data. All of you struggle with this. How do you bring reams of data to the next doctor? We hope we'll have better choices for you in the future. All of us are very interested in this. In the same way, we hope that we will eventually have data containers that help you keep your information straight. So when you go from Dr. Bolognese to Dr. Ruhoy, to Dr. Kaufman, to Dr. Lowe, to Dr. Constantino, that the notes will be kept together in a narrative that doesn't require you to repackage it every time. So we hope that this will become real in the next several years. I'm working with a couple other rare disease groups to try to bring tools to this space. So we're here for you. It's not perfect. We're not perfect. We don't have all the answers, but thank you so much for entrusting Ensemble. Thank you for trusting us to try to take care of you. It's our honor and our pleasure. And welcome to this webinar. Thank you very much.
Thank you so much, Dr. Huey, for your presentation. And then next, before we get into the panel discussion, we're going to hear from Dr. Costantino, who will share about his team's work with jugular decompressions at Northwell.
Great. Let me do the screen share. Hang on a second.
I've made you a co-host, which may help. Okay, perfect.
Great. So I'd like to thank Larry Lowe for actually getting me involved in this a long time ago, along with some other doctors such as Amir Dadashti. This is not a formal presentation, and I've got to give the warning that it is essentially all intraoperative photographs. And so anybody that is disturbed by those should probably blank their screen. But I thought that it was very important to present what Larry and I are doing, which I think deviates a little bit from the standard, and that we've adopted a very comprehensive approach at these decompressions. What Dr. Huey said, I echo. I've never seen so many patients who have been gaslit unintentionally. It's all in their head, it's behavioral, it's chemical, it's whatever. But at the end of the day, and this is a real problem. And the more I've gotten into treating patients with this problem, the more I realize not only how real it is, but how unrecognized it is in populations that are otherwise considered to have spontaneous CSF leaks, pseudotumor cerebri, a whole bunch of other disorders that we didn't know the cause of. And
I can't tell if it's just my end or if you might be frozen. Yeah, it sounds like you're frozen for a few of us.
Give me a minute. Can you see me yet?
Yeah, we can hear you again. We just couldn't
Sorry
hear
about that.
for a moment.
I'm in Greenwich, Connecticut, and they don't allow people to build cell towers, so there's a little bit of patchy service. I apologize.
No worries.
In any event, so this is real, and I appreciate the collaboration with Larry. And my background is not as a venous vascular surgeon. I'm a skull-based tumor surgeon. And the approaches that we use to get to the skull base, to the clivus and the foramen magnum, go right through this area. And many times we'll move the vertebral artery over or move the jugular vein or transect it and to take out these tumors. So we've approached this from a bit of a different standpoint than just ENT or standard neurosurgery. Larry is a complex spine surgeon. I don't do too much ENT. I mainly do head and neck and cranial base surgery. So I'm going to show just a few slides that really typify what we try and do with each and every patient. And though we tailor what we do to the individualities of the patient, both before and what we find during surgery, we try and achieve the following. And so here's the first slide. This is your classic transverse process compression. You can see the jugular vein here. You can see my forceps pointing to the area of compression. And this is the transverse process, pushing directly into the jugular vein. The styloid process is under here. The digastric muscle has been removed, but a big angle to that vessel. Let's go to the next slide. This shows that after Larry's removed that transverse process, you can see the vessel is entirely enlarged and the consistent diameter extending essentially from the mid-neck, the omohyoid, all the way up into the jugular foramen. With that, you look at the styloid process. Everybody focuses on the length. Here's a styloid that's a little bit longer than average from a female. It's relatively thin. Here's another styloid process. It's about a little bit shorter than average in a female, but it's very thick. And then here's a styloid process that's thick and very long. Ultimately, whether they're long or thick, it really doesn't matter because it is rarely the styloid process in our experience alone that causes the compression. It is always conspiring with another structure, primarily the transverse process. Now, I've got a comment on what I consider the difference between a vascular compression with venous congestion and pure Eagles syndrome. Classic Eagles is a long styloid that's poking you in the neck and it hurts there. Those patients may not have any venous congestion symptoms whatsoever. And when we simply remove the styloid for that type of a scenario, the success rate is uniformly high. On the other hand, a thick, short styloid that is adjacent to that jugular foramen, that's conspiring with a transverse process to compress the jugular vein in the distance between the base of the skull and the transverse process, that's a problem. So it's not so much the length of the styloid, but the three-dimensional anatomy of multiple structures. And we've started to realize that there are other structures involved as well. There's the occipital artery, rarely talked about, but here you can see spinal accessory nerve, the jugular vein that has not yet been dissected and had a fasciotomy, the transverse process, which was very exposed and posterior and pushing into the back of the jugular vein, and an occipital artery, which is clearly indenting the jugular vein. This artery, though it has a name, has no significant use. It doesn't supply anything critical. You can remove this segment across the vein without any ill effects. It doesn't feed anything important. The digastric muscle has been removed here so you can see it. We do that routinely. I'll mention that in a moment. But we consider this occipital artery one of the components of a constellation of anatomic structures that can contribute to compression. And we don't ever want to do a procedure, and after we're done, we're like, well, we wish we had done more. Because the first time you have this operation is by far the most fruitful. When you get reoperated, it is much more challenging. And here you can see the occipital artery. Here's the jugular vein and the occipital artery in another patient. And you can see after complete decompression, a wide open jugular vein, the occipital artery removed from this area, spinal accessory nerve is way back here, but this was contributing at least to some compression in this vessel. It needs to be addressed at times. Beyond that, the digastric muscle, we routinely remove this muscle. And here's the jugular vein, spinal accessory nerve, carotid sheath area, and this is the digastric, not providing compression here, but we remove that posterior belly. It is not necessary. It doesn't do much in humans, doesn't do anything in humans, it does more in canines, but ultimately it provides access to the infratemporal fossa for the styloidectomy and to make sure that you're decompressed all the way into the jugular foramen. Then the spinal accessory nerve, another structure that is under-recognized as a compressive feature. Here's the jugular vein, here's the spinal accessory nerve. Now let's look at this jugular vein. This is the spinal accessory nerve that we've mobilized, and I've moved it down. This dent in the jugular vein was compressing it. That is not seen on scan. It's not seen on venogram. You can't tell that it's the jugular vein. The only way that I can tell is during an operation. And we are very careful to try and mobilize this nerve while preserving its vascular supply called the vaso nervosum, because you can end up with nerve dysfunction as a result of it. But it's interesting, some patients complain of shoulder pain before we operate. I'd love to get Dr. Lowe's perspective and Dr. Bolognese's that I believe this nerve may be under tension, which could be causing that preoperative symptom, but you can clearly see the indentation of that vein. So with that, those are the structures that we tend to target. And it's not one, it's a constellation. We tailor it to the individual, but if we don't look at all of them, we end up regretting having not fully decompressed that vein, which would then give the patient an option for stenting, which we prefer to only do after bony structures have been removed. So that's kind of our philosophy. Larry, any comments?
No, thanks, Pete. I think that summarizes sort of our approach sort of very well in terms of sort of a comprehensive approach and sort of taking it systematically from sort of the base of the jugular vein all the way up to the skull base. So
Yeah, thank you so much, Dr. Costantino, for that presentation. I know it's really exciting for patients to actually get to see what's happening in these surgeries. So yeah, thank you. Next, we have our panel discussion. So some of these questions are going to be directed at specific physicians, but for the rest, Dr. Huey, we'd appreciate your help in directing them to the panelists you feel have the most relevant expertise, like you did last time, which was very helpful. Any of the panelists are welcome to expand on the first doctor's answer and offer their own opinion. And I know the audience always appreciates hearing from multiple physicians. So yeah, please do jump in with your answers. Some of these questions do have a few components, so don't hesitate to ask me to repeat anything if needed, or just check the chat because Austin, who I think is going to show up as committee member, will be pasting the questions there for easy reference for both the panelists and the attendees. We'll start with some more general questions about EDS and venous congestion, and then get more into specifics as we proceed, with much of the discussion focusing on surgical techniques, outcomes, and decision-making for patients. So our first question is, what are the typical symptoms of cerebral venous congestion in EDS patients? And are there any notable differences in how these issues present in people with connective tissue disorders? How common would you say EDS is in the cerebral venous congestion patients you've treated?
I'm going to start this, and then I'm going to move to Dr. Bolognese, who has a lot of experience in this space, and probably Dr. Ruhoy as well. We don't know in terms of the relationship and frequency of EDS, and it's one of the surveys I intend to eventually do with EDS patients with permission with Dr. Ruhoy, Bolognese, and the community. We need to know. It's pretty common because EDS is rare, and Kyle's clinic, Dr. Farjan's clinic, and mine have a lot of EDS patients. And so if there isn't a substantial amount of overlap, that's just not, it's highly improbable there's not a substantial overlap. What we think, so first of all, let's start with venous congestion. We've developed a new severity scale. The first publication just came out called CVDSS, Cerebral Venous Disorder Severity Scale. It's an alpha. It will change, but the objective is to get most of the symptoms that we've heard into a single scale. We're going to then start distributing this amongst all of us, and then we can critique it. And in a couple of years, hopefully we'll have a more stable one. But if you read the old papers from Dandy, from Quinky, and I'm blanking on the second German doctor, the symptoms that patients have are substantially more than what has been called IIH. IIH has been dumbed down to headaches, hearing your heartbeat in your ears, and vision loss. And if you read Dandy's old paper from 1937, it's substantially more. And it really matches what we're talking about these days. So I would say the most common things that bring them to us, bring you to our community, would be pulsatile to ENT. Your collaterals feel like pressure. So you'll feel pressure in your sinuses or behind your eyes or in your throat. That will bring you to ENT. Headaches in the back, occipital headaches, that will bring you to headache specialists. Pressure in the head will bring you to headache specialists. Migraines with auras, i.e. visual disturbances, brings you to ophthalmologists or neurology. And so each of us see different features of it. Cranial nerve palsies. I've seen every cranial nerve pissed off by this set of symptoms. So the reality is basically your head's messed up in vernacular terms. And that's literally what it is. It's not shocking. If you take your hand and just gently compress, what you're doing is causing venous congestion of your hand. Your hand starts feeling funny. Everything feels off. And that's how your brain feels. And teaser, most of us are involved in a new book. Paolo, I think I'm going to need to call you and ask you to join. And Dr. Kaufman, you as well. I apologize. But we're publishing a book called The Other Side of the Heart, and the opening chapter is Strangled from the Inside. And I think that describes a lot of your experiences. So that's that. And I'm going to cede to Dr. Bolognese, who has seen so many EDS patients over the years, on his feeling about the overlap.
Actually, I'm going to pass to Eileen first, because the article in which Eileen is the first author just came out 7 days ago. And when she's finished, I'm going to add from the neurosurgical standpoint.
Okay. I have a lot to say about IIH, and I agree with what you said, Ferdinand, that it's been dumbed down. And I think on a daily basis, I have conversations with neurologists over how IIH is completely misdefined, misdiagnosed. The EDS patient population, so hypermobility is clearly a risk factor for it. We've seen IIH in our study that we had done with those who had had fusion for CCI, and their symptoms are wide and varied, right? So it's not just the pulsatile tinnitus, it's not just the headaches, it's all the cranial neuralgias, as you mentioned. It is absolutely headaches. It is cognitive dysfunction, where they describe it as brain fog, but there's a clear cognitive problem that they're having a difficulty processing new information, which is unusual for them. There does not have to be visual disturbances, though there often is, but it's not in the classic way of like loss of vision as we were trained as neurologists, that was the real risk of IIH, of loss of vision, which can be permanent. It is often different kinds of what I think of as retinal hyperactivity, cortical hyperactivity, which is like visual snow, changes in their visual field, changes in their visual acuity that don't necessarily come up on visual acuity tests, which I can't really explain at this moment, but there's clear visual component that is not the classic loss of vision that we had always been taught with IIH. And sometimes there doesn't have to be papilledema. In fact, in the EDS patient population, there is definitely less papilledema than we would expect based on pressures of intracranial pressure that are elevated. And also, I'll point out that in the EDS patient population, normative pressures are not what we consider elevated pressures in a classic normative sense that have been published, that are the numbers that we sort of toss around in a more classic conventional way. They seem to have lower numbers, but it's representative of elevated pressure for them. And I think it's got something to do with just sort of the architectural integrity of their meninges, which are connective tissue. So I think there's a lot that we have to learn about IIH and its relation to venous congestion, specifically the jugular venous congestion. And it's just different, and it's varied. And I think that's a challenge for all of us, really, is to sort of accept the fact that these patients are truly suffering, despite the fact that they don't fit inside that box or in that textbook definition. And that is something that I struggle with, like I said, on a regular basis. And I think that's a really important factor. And we have seen in our study from our surveys that a great majority of patients present with symptoms that are related to elevated intracranial pressure, of which we actually had documented because we do intracranial bolt monitoring with the invasive cervical traction, the ICT. And so it's such an important point, and I think that's where a lot of patients get gaslit, frankly, and they just sort of are told that they don't have elevated intracranial pressure. In fact, I've had other doctors tell patients not to follow, my recommendations of taking the classic medications for it, right? So that's why I say it's a constant struggle of trying to redefine all of this. And I think it's an important thing to do for these patients. Paulo?
Okay, from my part, I got there from a different and winding road, which was when Milrat and I, when we were in Northwell, started stumbling into the neuro-EDS population. Our first problem, one of the first problems, was idiopathic intracranial hypertension. And it was easy to see that the patients were getting better after lumbar puncture, and the intracranial pressure, the lumbar puncture reading were high. That's great. And the only thing we had at that point, since idiopathic for the patient is a Greek word which means translates in we have no idea where the cause is coming from. We're putting the next best thing to a repeated lumbar puncture, which was a integral peritoneal shunt. The problem is that in these EDS patients, integral peritoneal shunt were failing at a rate which was incredibly high. So we were in the predicament of doing multiple shunt revisions, to the point that we were doing between every week we were doing either a shunt insertion or a shunt revision. Then one day, somebody started figuring out that the compression of the jugular and the dural sinuses were having a substantial role in the idiopathic. So at that point, it was not idiopathic anymore because we were identifying psychosis. So a big chunk of patients were like that. In interventional neuroradiology started playing with the stents, especially in the right transverse sinus, and then the next obstacle was the jugular vein at the level of C1. A few years ago, I started tackling the C1 tubercle from a different direction. Dr. Constantino and Dr. Lowe do, but practically we're shooting at the same target, simply different trajectories. And since I started decompressing the jugulars, right now my incidence of shunt revisions from 2 or shunt insertion and revision from 2 per week dropped down to 2 per 3 per year. So obviously we are in the compression of the jugular vein is at that level has a big role, and I'm very glad that that we're hitting the target, and I'm very glad that we're all having different experiences and different perspectives in it.
Thank you so much. Would anyone like to add anything? You're more than welcome to.
I'm going to throw out 2 things. Compliance. So for probably nobody remembers their electrical engineering, but basically compliance is about how stretchy things are, how much it can contain excess. My view is that we measure very high pressures in here. When we go to the neck, in the veins, the pressures typically drop. If we the veins can't stretch very far here. It's in a rigid place, so there's not a lot of compliance. When you're out here, the veins can stretch a lot, and presumably EDS, you stretch more than a normal person. In a normal person, we rarely see non-EDS. I shouldn't say normal. I want to be right language, but in a non-EDS person, these with more normative stretch characteristics, more normative compliance, we rarely see pressures gradients of more than 2 or 3, maybe 4. My guess is this is why EDS, you guys, we never see this, because your entire system is extremely stretchy. And so even you're miserable, but your numbers don't correlate with a non-EDS patient. I have recently seen some patients with scleroderma. They are your opposites. They are petrifying before us, and they're miserable because they have no compliance. So Eileen, I don't know if you want to add anything to that, because I suspect you see scleroderma as well. But I just want to let you guys know, EDS patients, when you see somebody who's not one of us and they don't give you the numbers, they say it's normal. Get the numbers. Get every piece of information you can, because they simply don't understand you. And it's not an insult to them. You just have to get everything. Don't listen to them when they say, oh, it's normal. It's not normal. Well, it might be normal, but keep everything.
Yeah, no, I completely agree. And it is true. I think one of the things that has to happen with patients, especially at initial appointments, is you have to do a full exam and laboratory work, which I am shocked at how many patients come to me and they have not had any lab work, that doctors just refuse to do labs. And I don't really understand it, because take scleroderma. I find the antibody not infrequently, not often, but not infrequently. And it's important because it does tell me how compliant their connective tissue will be, and it can easily explain a lot of their symptoms. And then on exam, frankly, you can feel and see a scleroderma process as you can a hypermobile process or a connective tissue process as an EDS. And so I think that the art of medicine I don't think anyone is doing full exams any longer. And I also don't think people are doing as extensive workups as I know I do and Dr. Kaufman does, because, we're not surgeons or interventionalists. So that's where we put our value in what we can find for these patients. So we do fairly extensive lab workups and we find things, and that's an important point. And so I agree. The connective tissue can do a whole lot of things, and it's important to try to identify what exactly is happening because it can explain the symptoms and importantly, it can also help tailor the treatment.
Dr. Rubroy, I voiced that also beyond just the EDS. We have 3 patients we've identified with chronic Lyme, one with an adrenal tumor, and another with a mild progressive cardiomyopathy.
Oh, wow.
None of them needed surgery, and all of them had symptoms directly related to those findings.
Yeah, absolutely. Those are perfect examples. I think that I do worry that there are wastebaskets that, people who are diagnosed, I mean, even with EDS, people are diagnosed with EDS. And so everything that they are concerned about or bring up to their physicians will say, well, you have EDS. Things become wastebaskets. And I always say we have to make sure we're not missing anything. Just because you hold this diagnosis, just because you have mast cell activation disorder, we can't blame it all on your mast cells. We have to make sure there isn't something more happening. So those are great examples.
Dr. Kaufman, you're unmuted, so I don't know if you had something you wanted to add or if anyone else wanted to add anything. Otherwise, I can move on.
Yeah, actually, I have a couple of things I can say. Adding to what Eileen just said, what Dr. Roy just said about the workup, I think the other thing I'd emphasize is the absolute primacy of taking a comprehensive history and listening to that patient from kind of a day one to the present history. You just learn so much. And when you hear it as a physician who's seeing a patient that's probably been to a dozen other doctors, you can begin to assemble, you can begin to entertain the diagnosis, and you can see why they've been pushed around and not listened to because they don't fulfill the usual criteria, the usual measurements. And that's partly because, as has been said, those measurements are coming out of a normative population. And up until relatively recently, the position of EDS and connective tissue disorder has essentially been ignored from putting together normals. And similar to what was said, I think, by Dr. Ruhoy and Dr. Lee, is those numbers don't necessarily apply to our patients, but that doesn't mean they're not sick. And for me, the example totally unrelated to venous congestion is POTS. If you don't go over 30 beats, you don't have POTS, but that's ridiculous. If you stand up and you have orthostatic intolerance and brain fog, and you only go up 27 beats, you still have POTS. And it's the same thing with this kind of problem. We need to take a history and put it in the context of the patient. And I'll say one more thing, which I think Dr. Constantino was alluding to. You also don't have to have EDS and connective tissue disorder to have these problems. People with connective tissue disorder generally have it from day one of their life, and they are not necessarily symptomatic until day 32 years old of their life. And very often that happens because of some infectious process that has kicked it off, pushed them over to the edge of the cliff. And we see people without prior connective tissue disorder who get COVID, long COVID, and venous congestion disorders and POTS, or get, as Dr. Constantino said, Lyme disease or EBV reactivation. So it's an important concept. You don't have to have EDS and you can still have these problems.
Thank you so much. We're one question in, and I'm already feeling fascinated and validated. Our next question is, having EDS can complicate treatment for cerebral venous congestion. In what ways is your approach to treatment different in patients with EDS?
I'm going to start by passing the ball. But I will say this, and I will defer a bit to Dr. Ruhoy and Dr. Bolognese and Dr. Kaufman. but I start my conversations with every EDS patient with, I've never seen any of you get to 100% happy. So let's set the expectations lower and we're going to try to make you better. So with that, I'm passing the ball to Eileen.
So I mean, ultimately, I'm going to let Dr. Bolognese speak, but I will say that he has not, and I don't take credit for it. He has developed a team over at Mount Sinai to treat EDS patients that are second to none. So they know what to do from the anesthesiologist to the plastic surgeon who closes the wounds. Like there's a phenomenal team there that takes these EDS patients from start to finish, and they know exactly how to treat them. And so I can definitely let him speak about it more. I know that there are some articles about anesthesiology for the EDS patient population, surgical considerations for the ED, and I share those articles with my patients when they're heading for any kind of surgical or neuro intervention, because there are things to know. But Dr. Bolognese, do you want to talk about your team and how they know what to do?
Yeah, it takes a village, that's for sure, and which implies two. I want to keep it short because as an Italian, I tend to ramble. The first one is all the comorbidities which come along with EDS when somebody has a venous congestion slash intracranial hypertension. So when you start having muscle and MALS and dysautonomia, your entire team needs to be, ready to, to push back everything the patient and her own EDS, because most of them are women, are going to throw at us. And hence, it takes a village, and the village is made by all the members and specialties that Eileen was mentioning. On the other side, there are technical issues which are raised about EDS whenever you do surgery or interventional procedure on this patient. And people with EDS do not heal well. They have very delicate tissues. They have, because the mast cell, they have inflammatory and immune and, any kind of reaction you can imagine, they're off the scale. So you had to be mindful of that. So you had to have a plastic surgeon who's going to be, either he's an expert or is going to become an expert with that. Whenever you as a surgeon or an interventional radiologist are going to make a procedure on that, you're going to have even more of a gingerly approach and more, it's like playing with China that you do usually. And then there is a lot of things that are going to come for your daily experience, especially from the things that they were never in the books and you learn the hard way.
Thank you. Would anyone like to add anything? If not, we can move along. So the next question, this one's going to initially be more directed to you, Dr. Bolognese. So for EDS patients, how important is it that surgeons or doctors try to see around corners by screening for potential comorbidities and neurological manifestations rather than approaching them one at a time? I'm starting with you since I know you give all patients a very extensive screening questionnaire that you've developed that for folks who aren't familiar with it, it inventories symptoms of different neurological manifestations of EDS and also comorbidities. So yeah, we'd love to hear more about how that's been helpful for you.
Dealing with that is like, when you're the first guy going in dealing with something that is not codified, it's like you're a guy that you're opening the door, you close the door behind you, and you're in a room full of furniture, and the room is completely dark. So the best way for you to create knowledge about the plan of that room is just to go around and to know where the furniture is by the way it hits your shins or it hits your face. That's when you're the first. Then when you're the second, hopefully you're going to hear from what the first has done. And we're still figuring out how many pieces of furniture are in the room. Right now, 25 years later, after the first time that somebody got in this room, we already have a list, and and it's not over yet. And Venous compression is one of them. MALS, mast cell, is dysautonomia, POTS, the tether core, craniocervical instability. So these are all things that we have found so far. The important thing is that we are not complacent that that's the end of it. Mirat and I were we did that mistake after the first 5 years, and then we kept getting our face slapped. So fortunately, right now there is more literature and more focus than was initially. Initially, we were talking to nobody because nobody wanted to hear. Right now, we're a big group of people, and we're like-minded. We're looking in the same direction, and many more people are going to jump on board and approach from a different corner, different directions, different techniques, different mind frame. For example, Dr. Costantino before presented his way of approach that area. It's not the way I do it, and I'm very fascinated by the way he does it. I'm going to look into it, etc. So when a lot of less smart and more smart people are approaching the problem, is going to be the hive approach. The hive approach is you're not going to have one person figuring everything out. The best solution is going to come from many people together.
I just want to say goodbye. I'm going to do my next stroke. I will propose, Paulo, I think you're good as a quarterback. So would you be the quarterback to pass the ball when I'm gone? Take care,
Very
everybody.
good, because it gives me the opportunity not to talk anymore.
Good luck
Bye.
with the stroke.
Yeah, I appreciate Dr. Huey being here while he could, and obviously it's very important that the physicians prioritize going to deal with their patients when they need to. So thank you, Dr. Bolognese, for being willing to help quarterback, as Dr. Huey said, though I will be hoping that you continue to answer the questions as well, since I know all the attendees are very excited to hear from you. Would anyone like to add anything about the seeing around corners and screening for comorbidities question, or should I move on to the next one?
Yeah, excuse me, I would like to add something to that. So as a referring physician to Paulo, to Dr. Bolognese, I make every effort to see around all those corners before we send the patient, and not just to find what's hiding behind the corner, but to manage it, because I see my goal, my job as the internist and referring physician, to maximally optimize the management of all these complications that are part of this complex illness that is plaguing this patient. So it's not just a question of diagnosing mast cell activation syndrome or POTS or an infection. I shouldn't even send that patient until I've done that part of the job of managing it as best as possible, which doesn't mean I'm always successful. And when I say I'm speaking for all of us, obviously. And to some degree, there's a obstruction to success, because sometimes the actual problems I'm referring to Dr. Bolognese for are preventing me from managing even better. So there's a limit to what medications can do. But at the same time, it really is our responsibility before referring or while referring to maximize that management. It's really important. So the question that whoever asked that question is really crucial. Sending Dr. Bolognese or any of the surgeons here today, patients without having looked around the corners and attempting to manage those symptoms, that's a true disservice to the patient and to the surgeon.
Thank you very much. I think you're anticipating my next question a little bit. So some of this might have been covered slightly, so feel free to just expand on it. And I suspect that Dr. Kaufman and Dr. Ruhoy will want to answer this one. So the question is, do MCAS, autoimmunity, and infections, particularly COVID and tick-borne infections, contribute to compromised connective tissue? If so, by what mechanisms? And then would you recommend trying to maximally control these factors prior to surgery for venous congestion, which you, of course, just segued into beautifully?
Yeah, I mean, absolutely. I think, first of all, I think it's important to recognize that a lot of people refer to connective tissue as just having a structural and mechanical role. And actually, it's a very dynamic physiologic, it's an organ, and it's present throughout our bodies in different forms. And there are so many different collagen types. I've already mentioned that the meninges are connective tissue. I mean, we commonly think of joints. In fact, that Baton scale, I think, is a little bit foolish. It's just 9 peripheral joints. What does that really tell you about the health of the connective tissue of any individual patient? And so I think it's important to recognize that there's a lot of physiology that actually goes on within the connective tissue. Most importantly, there's immune activity. So there's actually what we refer to as antigen presentation that goes on within the connective tissue elsewhere also. But within the connective tissue, there is antigen presenting cells that are present in connective tissue that are presenting antigens to B cells, and there are antibodies being created. There's a very high concentration of mast cells that reside in the connective tissue. And so the mechanism by which there's further degradation of connective tissue, which of course is not what an EDS patient needs nor wants, is the mechanism is by this immune activity. So once the mast cells are hyperactivated, they're just releasing and degranulating their insides, of which there are 1,200 mediators. All of them are inflammatory. Some of them are pain-inducing. There are some enzymes that break down, that target collagen. So it's just further degradation, as I had said, and that's the mechanism. And then there's the adaptive immune system, so the antigen presentation to the B cells making the antibodies. Then you eventually create autoantibodies that are now targeting pieces of the connective tissue because there's cellular damage. And I can go on, and I know this is sort of a lot of like in the weeds kind of thing, but this is what's happening in the EDS inflamed body, usually from an exposure, which is why I think, in my opinion, and we hope to prove this, but is that the hypermobile EDS patient population is at greater risk for diagnoses such as long COVID, such as ME/CFS, such as chronic vector-borne disease, and so on, because of all of this activity that goes on within their connective tissue. And I think this is important. And I agree with what Dr. Kaufman said, is that before I send anyone for any kind of surgical intervention, I want to make sure that I could do the best I can to manage all of this and sustain the patient so that they're even a good surgical candidate. Because if all of this were just, wayward in their bodies and chaos, like they're not good surgical candidates, or at the very least, their post-op recovery might be compromised because we didn't get all of this under control as best as we can preoperatively. And so that's sort of how I often see my role, at least as just a neurologist. It's the best I can do for them. Anyway, so that's my answer to the question.
So ultimately, we want to be in the position in which surgery is no longer needed for this.
Right. Yeah, that would be ideal, of course, is to prevent the surgeries. But, as we always talk about, all of us on the panel, once there's an anatomical problem, I mean, the best of all we do is not going to correct that necessarily. So, so surgery is in their future. The best that we can do is try to make that surgery, a successful one, right? Where they're not sorry they did it, kind of thing. So
yeah, but
that's
none of these surgeries is curative, number one.
Well,
Number two,
then
like Ferdinand was saying before, is more like a game of blackjack. So you have 2 cards and you're 16. What you gonna do? You're gonna hit again, or you're going to go over?
Right. Sorry, my computer was about to die. Right. No, I agree. I agree. The surgeries aren't curative, but the surgeries are definitely palliative, right? Especially the surgeries that Dr. Constantino was showing, which I too was fascinated by. The occipital artery, my gosh, cranial nerve 11. I never even considered those anatomical pieces, but I agree they're not curative, but they're definitely palliative. When they're indicated and when all of this is sort of managed for the patients, they for sure improve symptoms in the majority of patients. Not all, I agree, but the majority.
And as a follow-up, could I ask, how rapidly do you see like obvious signs of connective tissue degradation following things like infections or mold exposure, or any of those processes?
Yeah, that's a good question. And I think that there's probably a varied answer based on the individual patient, but it's certainly not immediate. I mean, lots of patients, give a history of, yeah, I had a viral infection and then I got better and I seemed to resolve back to my baseline, but then I had another and then I had another. So I think that there's a stepwise, sort of deterioration, if you will, over time, that then it results in sort of this inability of their loss of resiliency is sort of how I see it. And and it's sort of, they get to a point where then their lives are just not who they were, and that's the sad point of their lives, right? That's when everything that they are so used to doing, the person that they're used to being, is completely different now, and they can't find their way back. And the one thing that I do think, and it's that I do think there's a mitochondrial component here, and I bring this up now often only because I've been doing muscle biopsies, and 100% of the patients have some abnormality in the electron transport chain. And I think this is a secondary problem. I don't think this is a primary problem. I think this is a secondary problem because of, as I just said, the multiple exposures and the chronicity of some of these illnesses, right? In fact, with COVID, we're talking about, persistence, right? I think it's spike persistence. There's some talk that maybe it's viral persistence, but it's the persistence and the chronicity of some of these illnesses that I think ultimately becomes just this secondary burden on the mitochondria, of which those enzymes of the electron transport chain just start to fail. So then it becomes this. So yeah, and I think, yeah, I could talk forever. I'm rambling now, but I just feel like that we have to try to get the train back into the station for these patients. And if we can get them at least close to the station, or sometimes I say the horse back to the barn as close as we can, then I think that when there's an anatomical problem, that's when we have to have the surgeons and the interventionalists intervene to at least correct that the best way that they can, so that these patients have even a better chance of recovery.
If I could make a comment, you mentioned how it's a degradative process that takes years and is chronic and so forth. And whenever we're contemplating operating on an EDS patient, I'm very cautious. I participated in the development of a material called acellular dermis. It's used for all sorts of reconstructive purposes, and it's made from cadaveric skin, so skin from donors, highly processed. And we noticed in the early phases of developing this that we had extensive backgrounds on all of the donors of this tissue. And we had to eliminate anybody that had suggestion of EDS, because when you implanted that tissue, it went away very quickly. So it wasn't just the cellular component, it was the actual structure of the collagen was sufficiently defective that it elicited an inflammatory response in a normal recipient that chewed up the collagen and made it go away too quickly. Imagine that process over your lifespan, and also imagine the process where you've done surgery and now you're trying to heal that trauma. So it needs to be undertaken very carefully.
I completely agree. And not that this is necessarily a fair comparison, because what you do is way elevated beyond what I do. But even, I used to do open muscle biopsies, and I noticed that my EDS patients weren't healing. And that really bothered me. And so I looked far and wide, and I found these spherotomes where I do a punch muscle biopsy now. So no need for an open biopsy. It's a very small, I don't even need to suture. And they heal very well because I didn't need to open them. So it's not an exact comparison, but it is true that the EDS patient really is a very sensitive patient, and doctors have to take that into account when working with them, when treating them, when considering them, and they are at risk for a lot of these different things.
Thank you. Would anyone like to add anything?
Yeah, I'd like to make a comment about this as well. And the connective tissue is everywhere. It's kind of how we stay alive, along, I guess, with mitochondria. One of the ways I try to explain it to patients is a person without connective tissue disorder, without EDS, is like an empty glass, and a patient with connective tissue disorder is a glass half full. And as there is ongoing inflammation from infection or repeated reactivated infection or undiagnosed Lyme disease or undiagnosed Bartonella or Babesia, or constant inflammation from mast cell activation, and all these proteases and elastases and everything else are released, the person whose glass is half full overflows a lot more rapidly and runs into the wall or falls off the cliff. But the same can happen to the empty glass. It just takes longer, all right? And our job, the non-surgeons on this panel, is to prevent that overflow and slow it down. Many patients will say to me, well, what can I do about my connective tissue disorder? And the answer is that we as physicians have to aggressively look for whatever may be causing inflammation that is then leading to ongoing damage to an already fragile tissue. And it can be done. Unfortunately, I've seen the converse. perhaps before I understood this is better than I do now, where I had patients 10 years ago, and I literally saw them progress in their connective tissue disorder while I tried to deal with some other problem. And it was kind of like one of these aha moments of, wait a minute, this patient didn't start out with anything remotely looking like CCI, and now they have it. What happened? And, working backwards to see the problems that initially I wasn't educated enough to address. So it's a really important thing.
Yeah, thank you so much. That's very useful information to add. So the next question we have is, in patients with EDS, is the onset of cerebral venous congestion symptoms more likely to be gradual or sudden? And anyone can chime in. Dr.
Eileen, start from a neurological standpoint.
So what's the question? How quickly does it happen? Is that the
is the onset of cerebral venous congestion symptoms specifically? So I think we've covered it more for EDS, but we're looking for the venous congestion part.
I really don't think there's a definite answer or one answer to that. I think it's actually very individual to the patient itself. And I think that there are a lot of contributions to the development of cerebral venous congestion that we probably don't understand or have not identified yet. And it's very hard to know once a patient has cerebral venous congestion, whether it was gradual or sudden. Sometimes when you get a history, it sounds like it was sudden, but as we all know, things are normal until they're not. So it could have been building up, and then all of a sudden it's like the cup runneth over, and then you have symptoms. So it's really hard to answer that question. I don't think I have a good answer. Maybe someone else on the panel does.
So, Dr. Constantino, some of these patients have different degrees of venous congestion. Some of them have collateral circulation or not. So from your perspective, how do you think this collateral circulation plays a role both in compensating and also as a signal for us for surgical qualification?
That's a great question. And I kind of look at it this way. If you have 5 little tubes that are carrying the same amount of fluid as one big tube, the resistance with those 5 little tubes is still greater than that one big tube, because the resistance is inversely related to the diameter. And it's not the aggregate diameter, it's the individual diameters. So I think that those collaterals serve as a method of getting the same blood flow out of the brain case as went into it. But I think that the pressures are still elevated. And the thing that has always confused me is, if the pressures aren't always elevated, then why are these symptoms so persistent? And I kind of look at it this way now, that if you had a spot on your kneecap and you tapped it with a hammer a couple times, it would hurt for a moment, and then it would stop hurting. But if you did it every day, 4 or 5 times a day, after about a week, it would hurt all the time. And I think that's what's happening to these patients, is that they have these increases in intracranial pressure, and it causes changes in brain function and chemistry, synaptic connections. And even after the pressure gets back to normal, the residual effect from that trauma from the high pressures carries an ongoing impact on their symptoms. And so my standpoint is the collaterals are great in physiologically getting the same amount of blood out of the head as was going into it. But I don't think that they solve the problem that these patients are facing relative to the etiology of their symptoms.
Yeah, they're not the same. And there is also another mechanism that the old timers were quoting, which is the mother-in-law effect.
I don't know what that is, but I have.
Yeah, no, I know, everybody does. So there is a pathology, and then there is the clinical conversion. And sometimes the mother-in-law effect is just the different resilience that, sons-in-law can have for their mother-in-law. Somebody can have a very short fuse. Other people can resist for 15 years of abuse up to the point that they snap. So even in the face of the same degree of venous compression and consequence idiopathic increase of intracranial pressure, there are different kind of ways and timing in which the similar patients are going to have a symptomatic conversion, which translated in English means you can have a patient, same anatomy, that becomes sicker faster, and other patients is going to take a longer period of time to get sicker.
Thank you. Would anyone like to add anything?
I'm going to maybe be a broken record, but I'm going to go back to my glass overflowing. Okay. And Eileen sort of hinted at it. Dr. Ruhoy sort of hinted at it. You know, in terms of presentation, very often a patient comes to our attention or the surgeon's attention after that glass is overflowed. But that doesn't mean that it didn't take 9 years for the glass to go from half full to overflowing. And again, for me, that's why endlessly taking that history and asking questions and going back to the questions, going back to the history is so important, because you want to prevent that overflow. And the only way one of the ways to do that is to see what's causing the gradual rise in the glass. So yes, I think patients look like it's sudden onset, but it's almost never sudden onset unless there's some physically traumatic event, a car accident or ski accident or something like that. So that's it.
Thank you. The next question, which I'll start with Dr. Costantino, if you don't mind, is, in general, are there any differences in your diagnostic approach when it comes to cerebral venous congestion, specifically in an EDS patient population?
I don't know that there's a difference in my diagnostic approach, but I'm going to tell you that we are more circumspect about recommending surgery. The symptoms and the indications for surgery need to be much more defined, because you don't necessarily get the patient back to baseline after you've operated compared to the way they were before due to their flawed healing characteristics. So it's a bit of a one-way street. You better be as sure as possible that you're going to affect a positive impact on that venous congestion before you operate, because that surgery is going to cost you something. In most patients, what it costs them is scar tissue formation. And that scar tissue can be an issue in and of itself. But for an EDS patient, it's not so much the scar tissue formation, it's the permanent change in the structural stability of the tissues surrounding where we operated that concern me the most. So we're much more circumspect about recommending surgery, and we need very solid indications before at least I feel comfortable doing it. Larry, your thoughts?
I think that oftentimes when patients present to us with sort of concurrent EDS and jugular vein stenosis, invariably they likely have some symptoms, whether it's mild or severe, from craniocervical instability. And I think that for the patients that have already gotten an occipital cervical fusion, I think it's pretty straightforward in the sense that our decompression becomes technically a little bit more difficult, but at least we're not sort of introducing potentially new instability as we do the decompression. I echo Pete's thoughts in that certainly we are definitely much more sort of cautious as to take the de novo patient with the EDS that hasn't gotten treatment for their CCI yet to recommend jugular vein decompression, because in reality, although I'm sure Dr. Bolognese can attest to this more, I mean, the C1-2, the OC1 joint is very complex. And even though theoretically that we're not sort of sectioning any ligaments as we do our transcondylar approach to taking down the styloid process as well as the transverse process, that there is probably some structural support afforded by the tissues in the area. And in patients with EDS or just connective tissue disorders in general, we probably are potentially introducing at least a very mild degree of instability as we do the decompression. So that's where it comes to sort of a case-by-case evaluation and a good physical, which the other panelists have really spoken about, are, do you really think that the patient's coming with more sort of MCAS type symptoms? Are they having symptoms for the CCI, or do you think it's more of the cerebral venous congestion? And obviously it's not easy because it's usually all of the above, And that's where sort of we are trying to be careful to offer only patients where we truly believe that although they have all of these interplay, that their majority of their symptoms are from jugular vein stenosis, to sort of offer them the decompression.
And if I could make one other technical comment, a lot of patients come and they talk about shaving the transverse process and the shave procedure. Larry and I are very focused on going directly down onto the tubercle, which is like a little thumb that sticks up from the transverse process. And there's fascia on that. And I'd love Dr. Bolognese's perspective, but we do our very best to essentially core that thing out without stripping any musculature from the surrounding bony spinal constructs. So we really try not to disrupt any of the musculature that's attached to the spine. We go directly onto that transverse process and we resect it, not shave it, so that we remove its compression, usually posteriorly, onto the jugular vein and give that jugular vein room to expand. And you saw that in a couple of the photographs. So it's really a technical consideration that we think has a material impact on outcome.
In my approach is different because I come from behind, and it's in the context of other surgeries for the vast majority of the time. So it is all right. So I'm there. I'm doing a cranial cervical fusion. I'm doing a Chiari-1 malformation. Since I'm there, instead of doing another separate approach from the front or purely lateral, I'm already there from posterior walk through the posterior part of one, and I chop the entire C1 tubercle, which is a very technical way to describe it. And so it's just a sort of a crime of opportunity, given the circumstances and the overall picture.
Thank you. Would anyone like to add anything? If not, I have a bit of a follow-up that I'll start with you, Dr. Bolognese. So some patients with both CCI and jugular compression choose to start with a styloidectomy and or C1 shave before considering craniocervical fusion. So based on your experience, how do outcomes compare between those who undergo only jugular decompression versus those who address both the jugular compression and CCI surgically? And do certain symptoms tend to improve more with C1 shaves and styloidectomies versus with fusion? Can styloidectomies or C1 shaves exacerbate upper cervical instability?
Okay, that is more of a theoretical question than a practical one. Since most of these patients come with combo packages or more than one disorder together, the real question is not what you were raising, but the real question is, in the list of all the mechanisms, pathologic mechanisms, which are hurting the patient, that single patient at that point, what is the leaderboard? What's the gold medal? What's the silver medal? What's the bronze medal? And under those circumstances, and with that approach, you then ask a second question, which is a non-surgical physician or as a surgical physician, what's the best first punch that you're going to give to the entire house of cards in order to have the highest return? So you can have some patients, for example, who have instability, tether cord, and compression of the jugular. Okay, so in the ideal circumstance of a Disney movie, you touch with a magic wand and everything goes away. In the reality, that's not the case. So you have to consider the whole house of cards and to make the speculation and the decision at the end about what's the best approach. So in certain patients, like Dr. Constantino was showing before, in which there is a sandwich between two anatomical structure, you're going to make the call about which one is the biggest bun of the sandwich. If that involves two separate approaches. The other thing I was saying before, if you are doing a craniocervical fusion surgery and the compression of the jugular is just 3/4 of an inch away, you have the opportunity to take care of both of them. So there is not a single rigid strategy that gets you there. It has to be a kind of a tailored decision for each individual patient.
I completely echo Dr. Bolognese's sentiment about sort of evaluating the patients on a case-by-case basis. At least in our hands, I do think that I think if the patient clearly has sort of primarily instability type symptoms, then I think it makes a lot of sense in terms of sort of concurrently carrying out both treatments at once. Because obviously, with a posterior approach, you have a great access to the C1 lateral tubercle as well. I do think that oftentimes when we counsel patients about sort of whether they're seeking treatments for the jugular vein stenosis or an occipital cervical fusion, just from a relative surgery recovery perspective, I do think that compared to an occipital cervical fusion, jugular vein decompression with sort of a high cervical lateral approach is a, relatively speaking, easier procedure to recover from, even in patients who have hard time healing in terms of connective tissue disorders. Whereas, no matter sort of how you spin it, I do think that an occipital cervical fusion is a little bit more morbid. And sort of one of the studies that we had published looking at sort of this particular group of sort of IH plus patients is that um, the group of patients do have significant sort of extra jugular drainage, particularly through sort of the posterior cervical collaterals, as well as the condylar collaterals. And what worries me about sort of taking a patient with both jugular vein stenosis and a CCI with more cerebral venous congestion type symptoms to the operating for a posterior cervical operation first is that I do think that in surgeons that are extremely careful, such as Dr. Bolognese and others that are well versed in treating this problem, that they're extra careful in terms of the paravertebral dissection to preserve those veins. But oftentimes, what we'll see sort of on a post-procedural venogram is that a lot of those posterior collaterals are taken, and although they've gotten an occipital cervical fusion, which addressed their CCI, unless they concurrently had their jugular vein stenosis treated first, that their venous congestion symptoms are actually paradoxically worse after the procedure, because a lot of their native cerebral venous drainage was actually from the extrajugular network. So that is something that sort of I tell patients about when they're sort of debating between sort of what options they should pursue, is that there is some sort of material downside to undergoing a craniocervical fixation without a concurrent jugular vein decompression, if that's something that they're contemplating and they have both of these symptoms.
Thank you very much. Would anyone like to add anything, or otherwise I can move on to our next one? All right, so our next question is, what factors could explain why many patients experience only transient relief after jugular decompression surgeries? What contributes to the jugular not staying open even when compression by the lateral mass of C1, the styloid, and or soft tissue has been removed? And how often is it that the structural integrity of the veins themselves is an issue in EDS patients versus simply having compressed veins? And how often do these patients go on to require jugular stenting afterwards?
Dr. Constantino, you go.
So there's two questions there. So it's interesting, when I've operated on EDS patients, I notice the tissue quality is fundamentally different relative to the soft tissues, the musculature, even the subdermal tissues. But I have not noticed any significant difference in the characteristics of the jugular vein as I've dissected it and done a fasciotomy. Now, we know that the connective tissue disorder affects everything, but I don't believe that there's a material impact on the structural stability of the vein. And if there was, then it would mean that the vein was weaker and it would dilate. I have not reoperated an EDS patient who's had a stent placed. The stent placements that I've reoperated have shown enormous amounts of scarring, and I think are a different animal. With respect to what was the second part of the question, if you could read it?
Yeah, so it was, how often is the structural integrity of the veins themselves an issue? And then how often do patients go on to require an actual stent to be placed instead of just the decompression surgery?
Right. So the stents that I've seen occur after we've done a bony decompression so that the stent actually can do something, because I'm not sure what the stents do when the bone's still there. Those patients have not had EDS and have gone on to demonstrate scarring. And the vein was open in the beginning, and then you get a venogram even 6 weeks, but definitely 3 months later, and you can see that you've got a diameter that's less than what it was when it was opened. And that has prompted us to actually acquire a laser 3-dimensional scanner that we're still trying to figure out how to use it correctly, where we can scan the diameter of the vein at the conclusion of the decompression, so that we can actually have the physical parameters of the vein, the architecture of the vein at the conclusion of the decompression, so we can compare that to what we're facing 3 months or 6 months later to determine how much diameter we've lost as a result of the healing process and circumferential scarring of the vein. That's still in process.
Thank you. Would anyone like to add anything? And then on the topic of stenting, so how often do EDS patients experience lasting improvements from stenting? And are there different outcomes for jugular stenting versus stenting in the dural venous sinuses? And do EDS patients, are they more likely to have complications from stenting? And what might those be?
Yeah, that is more a question for Ferdinand. But I'm going to go to the kind of the flip part of stenting. The flip part of stenting is that once you have stenting and you're obligated as a patient to be on specific medications to keep your blood on the thinner side for the rest of your life. The second part of the flip side of stenting is that right now that there's been an experience with venous stenting for transsinus, etc. We are starting seeing, especially in EDS patients, there are some problems about post-stenting stenosis, and some intervention radiologists of high level, like Ferdinand and Caton and the others, they're actually starting exploring, doing in-series stenting in order to rescue the patient from this. The major problem for us is that once a patient is stented, then it becomes a problem to get in that area if you have to go there surgically because you're at risk of creating a dent in the stent or even worse. That said, like everything in medicine, you need to see the 10-year down the line perspective to understand all the repercussions, the final pros, final cons. For sure, there is a role for stenting and surgery. The two things are not equivalent. Obviously, if there is a big bony stricture / sandwich, the stenting cannot maneuver through that.
Thank you. Would anyone like to add anything? All right, so our next question is, how often do you find antiplatelet medications like Plavix or drugs to lower intracranial pressure like Diamox are helpful as part of a conservative management strategy for cerebral venous congestion patients? Can a positive response to either of these types of medications be predictive of a good surgical outcome?
David.
A really good question. I think the first thing I'd say for me as a internist, not a surgeon, not a neurologist, certainly not a neurosurgeon, is that if I develop a suspicion of a venous compression situation and the patient has improvement with acetazolamide, Diamox, I tend to see that as a kind of clinical confirmation, because it's often very difficult to initially prove it. Getting the imaging obviously is crucial. Getting it approved by their insurance companies is a nightmare. And I'm not going to sit around and wait for that while I try to get some relief for the patient. So, the response to treatment as is so often true in a lot of what we do, is critical to confirming or moving along the diagnostic workup. And the same is exactly true in mast cell activation. It's very similar in my mind. The way treatment can help us understand what's going on. My concern in the question is if the patient has a venous compression syndrome and they improve with Diamox, that's potentially a Band-Aid. And I think we need to find out what that compression is caused by. And if it's anatomical, which it usually is, then it has to be fixed. It kind of goes back to something that I have said over and over, and Dr. Ruhoy says over and over. If there's a mechanical problem, an anatomical problem, all the drugs in the world are not going to fix it. And it's hard to wrap our heads around it. As an internist, I spent 75% of my career directing patients away from surgeons. No offense to you guys. But now it's like I find myself directing to surgeons over and over and over because you can't fix an anatomical problem with Diamox or an antibiotic or any of the other drugs we use.
Thank you.
Yeah, I agree with what Dr. Kaufman said. I think that, I think it's important that when physicians prescribe a medication, they understand the mechanism of action so that if there is indeed a clinical benefit, you get some insight into what might be going on. But I also I don't believe it to be predictive of how they will do post-intervention to relieve the compression. I also, in fairness, I haven't really done the correlation of, oh, this patient had a positive response to Diamox and also had a positive response to decompression. So I can't say definitively, but I don't like to use medications as predictors of how they'll do post-operatively. But if they have a clinical benefit, it does seem to at least confirm what the physiology is that we've suspected and that we've diagnosed. So yes, so that's sort of how I see the use of medications in this patient population.
Eileen, you would, though, use their response to medication as a reason to move that workup along more rapidly and more directly
Oh, yeah,
okay.
absolutely. Because none of
Yeah.
these medications, I mean, you can't be on most of these medications for the rest of your life, first of all. And I will say that Diamox is very poorly tolerated at some point, and you have to worry about, of course, potassium supplementation and bicarb it's a sulfa drug, lots of allergies to sulfa drugs. And so there's a lot of reasons why a patient can't be on long-term Diamox. Although some people are at high dosages, but that's not a more common kind of scenario. So yes, I do use the response to the medication treatment to move the workup along towards a surgical intervention for sure.
All right, anyone else? All right, so some of our next questions have been addressed a bit, but I'll slightly modify it or add a follow-up. So the question was, how are shunts helpful for EDS patients with intracranial hypertension, or how often are shunts helpful for EDS patients with intracranial hypertension in the context of cerebral venous congestion? Do some of these patients still end up requiring a shunt even after they've gone through the jugular decompression and stenting of the jugular or dural sinuses as applicable? And are there shunt complications that are more common in people with EDS? Because I know Dr. Bolognese, you mentioned significant issues with shunts, particularly for folks who've not gone through the venous congestion treatment. But what about for folks who are having a shunt after they've gone through those procedures?
As I was saying at the beginning, the need for shunt and shunt revisions in the patients in whom I performed a decompression of the jugular has plummeted. So that's probably one of the best thing, to prolong my own life. The shunts in these patients have a lot of complications. Some of them are, for example, it's very rare for patients to have relatively to proximal failures to have distal failures, and the incidence of distal failures in patients with EDS is higher. The mechanisms of proximal failure in patients with EDS are definitely more complex and more frequent and not in the correspective population without EDS. So, what's a long-term problem when you just rely on shunts is that after a while you're going to do so many revisions over and over and over that you're gonna quote unquote run out of real estate. So you're gonna run out of safe places through which you can repeatedly and pass a shunt inside the brain to reach the ventricles. So it's a big blessing that we figure out this compression of the jugular and maybe less and less shunts. Another technical problem is that one of which valve and which hardware you use. Unfortunately, the majority of the hardware out there was designed and tested for hydrocephalus. The only hardware which is available for increasing intracranial pressure in people with small ventricles is a kiss of death for people with EDS, specifically the lumboperitoneal shunt. So I'm very happy that I don't have to deal with that anymore. Now, I'm interested to hear what Dr. Lowe has to say with his experience.
I think that just like anything else, I think the placement of a shunt in patients with poor wound healing obviously is a bit of an issue, especially if they have thin body habitus, and sometimes these valves are on a bit of the larger side. I do think that we haven't studied this extensively yet, but in terms of sort of the macroscopic drop in intracranial pressures post jugular vein decompression, what I typically tell patients is that we're not expecting like a dramatic drop. And so I do think that if you are the EDS patient that's experiencing more of the sort of classical IH type symptoms where you do have an elevated opening pressure or you've got symptoms of papilledema, so essentially more in line with the Dandy criteria for IH, then it doesn't surprise me that a jugular vein decompression sometimes may not be enough, and that ultimately you need CSF diversion, whether it's a VP shunt or a lumbar peritoneal shunt.
Thank you. Great information for patients to have. So as we're hearing, EDS patients can be very complex. How have your surgical methods and outcomes changed over the years that you've been working with this patient population?
For me?
Any other surgeons
Right.
would love for you to answer, yeah.
All right, so I'm going to start like every single surgery that I'm performing in the let's not fix only on the venous compression, but every surgery that I perform in the sphere of the neuro EDS is no longer the traditional surgery that I learned in residency, and I changed it and I modified it and I tailored it to the specific needs of the EDS on the grounds of all the problems that we encounter with the traditional surgery. So all the surgeries I do for EDS patients are custom built.
Dr. Costantino, do you want to add anything?
Sure. So I'm also a plastic surgeon. And if you look at EDS patients, they heal more slowly. They don't heal with as stable reparative connective tissue. And so you need to take that into consideration. So the techniques I use involve, very specific technical components. One, I prefer to do a dissection with what's called electrocautery at a relatively high level, because when it's used at a higher level, it separates the tissue without charring and it minimizes bleeding. And I don't want a lot of blood between the tissue leaves as we close the wound, because that interferes with effective healing, because it's got to be absorbed, and that with it creates inflammatory process. I don't want the electrocautery used so it leaves a lot of char behind, because that's a whole nother layer of inflammatory response that interferes with healing. Where I would normally use a suture, what's called 3O, for certain areas of closure near the surface of the skin, which is a smaller diameter suture, which traditionally we try and use smaller diameter sutures to leave as little suture material behind as you can achieve. I use thicker suture materials because it's going to last longer. It's going to stay there longer. The suture material the sutures are placed slightly wider apart, but they encompass a wider breadth of tissue. so as to not compromise the blood supply, the tissue being brought together by the tension of the suture. So without getting really in the weeds, the technical considerations that I employ for EDS patients are comparable to what we learned we needed to use in head and neck cancer patients, which was my original training as a head and neck surgical oncologist, because a lot of those patients have been radiated. They've been exposed to full course radiation, and then they end up having a recurrence, and you've got to operate on them, and they heal very poorly. So there are techniques that we develop for that aspect of patient care in oncology, post-radiation oncology, that I've applied to EDS patients, and it seems to have had a positive impact in wound stabilization and wound healing.
Thank you. And Dr. Lowe, do you want to add anything?
I think I echo a lot of the soft tissue things that both Dr. Bolognese and Dr. Constantine had mentioned. I think that specifically looking at a fusion, it does bring up sort of unique challenges because I think the craniocervical junctions are already one of the hardest areas to achieve a successful fusion because of how complex those joints are and how much motion you're taking away, let alone in patients that have a connective tissue disorder where they're actually hypermobile. So without getting into details, I think that's encompassed what Dr. Bolognese said, which is sort of evaluate on a case-by-case basis in terms of what type of implants to place, trying to match the patient's own alignment, what type of bone graft to use to try to achieve a successful fusion in this patient population. And it's probably arguably one of the hardest sort of like non-cancerous patient populations, non-radiation patients to try to get the bones to heal.
Thank you. So another surgery-related question, how does having MCAS or persistent inflammation due to infections or autoimmunity complicate recovery from surgery and impact surgical outcomes? Dr. Lowe, since we're just going, do you want to start with this one?
What we try to do is definitely work with our team to make sure that as much as we can, they're optimized, as much of their MCAS in terms of being on cromolyn, making sure their numbers are looking good, looking at their eosinophils and stuff like that. So I think all this goes to sort of a deep relationship with doctors like Dr. Kaufman and Dr. Tui to try to make everything as perfect as possible because, like I said, no question compared to your standard non-EDS patients that are either going on occipital cervical fusion or jugular vein decompression, that it's a little bit more high risk. So we rely closely on our partners because as a surgeon, like I said, at the end of the day, we're technicians. We rely sort of on our referring doctors to try to optimize the MCAS as much as possible prior to surgery.
Great. Would anyone
when I'm in trouble with muscle, I call Eileen, so I passed to Eileen the question.
Okay. Well, I think we've sort of addressed this, that it's important to manage the mast cell activity, certainly preoperatively, and then we are aggressive postoperatively to make sure that they're not revved up. I mean, I think that a surgical wound, the body, it's traumatic to the body, no matter what the setting is, all the general anesthesia in the operating room and, even despite that, it's still traumatic to the body, so it still can piss the mast cells off if they're used to being hyperactive. So there's very often a mast cell reactivity post-operatively, of which we're very aggressive at trying to manage that to ensure that there is a good recovery. And I think it's actually a critical component. And I see it as sort of part of the surgery itself, as part of the procedure to manage the reactivity of those mast cells following the procedure. And so we just have developed, we actually have a protocol of how to do that. That we have a pre-op protocol, we have an intra-op protocol, we have a post-op protocol. So we are really aggressive at trying to manage those mast cells. And as well as the autoimmunity, I think, it's a little bit harder to quickly address autoimmune issues, but you hope that you can get at least whatever autoimmune diagnosis that they may have under control prior to the surgical intervention.
And does the MCAS have any impact on scar tissue development, or?
It absolutely can, yes.
Great, thank you. That's good to know. All right, so are there particular symptoms that you find are generally more resistant to treatment? What symptoms do you find improve most frequently versus most infrequently after jugular decompression surgeries or stenting? And what about with craniocervical fusions?
I think I guess the question is for me.
Yeah, any of you can answer, definitely.
I think that's probably, I mean, for sure, things like headaches improve, things like tinnitus improve. Certainly, patients will say that there's improved energy, so there's less fatigue. Dizziness kind of, definitely improves. So I think that these all improve. To what extent they improve is very variable. So it's not like they are 100% resolved necessarily, but there's improvement in those symptoms most commonly. Definitely improvement in pain levels too, not just headache.
Pete, what are your thoughts? But at least sort of in our experience, I do feel like amongst the sort of the constellation of symptoms that perhaps the hardest is probably pulsatile tinnitus. I think that when we do a jugular vein decompression and we are blaming the pulsatile tinnitus on the jugular vein stenosis, the thinking is that essentially there's shunting of the venous drainage through the extrajugular network that's potentially causing the pulsatile tinnitus after you've ruled them out for more common causes such as sort of ear problems or dura fistula and things like that. So I do think that we don't understand enough about what the net effect is of how we're altering the jugular vein drainage post decompression. So I think that probably leads to the most sort of mixed outcome. I do think that, like what Dr. Tui is saying, that I do think that most patients report some type of improvement, but if the expectation is going back to what Ferdinand saying was that you want 100% of your symptoms gone, I think that's the hardest to hit a home run on. We've definitely hit home runs on headaches, energy levels, brain fog, things like that, but I do find it that, at least in my experience, that the pulsatile tinnitus is probably the single hardest symptom to try to resolve 100% post decompression.
I'd agree with you, Larry, with one caveat. I think that low frequency pulsatile tinnitus has responded well, but high frequency tinnitus does not. And the question is why? And I think that the high frequency tinnitus, and I've got no scientific basis for this other than an anatomic correlation that should make sense from a pathophysiologic standpoint, which is if you have high venous pressures, and particularly the sigmoid sinus, and the endolymphatic sac drains perilymph from the inner ear through that system. If you have chronically marginally high endolymphatic pressures and perilymph pressures, I think it causes damage to the cochlea. And I think that the high frequency tinnitus is from chronic increased pressure and damage to the actual cochlea itself, whereas the low frequency tinnitus is more an actual transmitted sound from, as almost like a bruit, from the venous system. So, and the other thing is, I've noticed that over time, patients who have unsteadiness and dizziness over time seem to get better. And that correlates also with endolymphatic sac pressures that are too high, because that sac drains perilymph through the venous system, which is too high. And as we fix that, I think that they have a material, though delayed, response.
I totally agree. The high pitch area is actually that one that neurodegenerates progressively over the lifetime. So that's why the older people cannot hear those parts of the spectrum anymore.
It's the same pathophysiology as being exposed to loud noises over your lifespan, and you get exposed to these high pressures over a long enough period of time, the membrane in the cochlea just doesn't recover.
So your inference is that listening to women who have a high-pitched voice ruin our ears.
I'm sorry, my speaker went out. I could not hear you.
Dr. Volany.
One comment now that I'm back.
Hi.
We do occasionally see improvements in high-pitched tinnitus after fixing CSF leaks. I don't think we see it as much from the high pressure side, but this is an area where, as we mature, we really should be working with the otologists and audiologists more clearly, because most of the endovascular people are like, do you have tinnitus? Is it pulsatile or high pitched? No more information is needed. Is it better? Is it worse? So we're not tracking this data. So as we mature as a field, I think this is going to be very important and interesting.
Is there any utility to getting audiograms?
We're starting to get them on everybody, but in the beginning, we didn't get them on anyone.
Yeah, I haven't been ordering them. Do you think it should be part of my workup? Is that
Yeah,
useful?
yeah, absolutely. We're ordering them because I don't know what I'm going to find. And you want to know the truth, you probably ought to do even an ABR, but that's just too expensive and not worth it.
Okay.
Since we're on,
Ferdinand, there was a question about stenting, so I'm glad you're back.
I couldn't hear your question. I'm going to borrow from Dr. Constantino. I'm kidding. It was a joke. I want to address one other thing about tests. We are talking with the neuro-ophthalmologists who have admitted happily at the Nanos meeting. I went and sacrificed myself and met with their board to talk about collaborations. They did say that, and I know a bunch of them from when I was in training, so there's a little bit of benefit there. But I asked, you guys know that these patients complain of visual defects. They're not always Friesen scale positive. What do you think about that? And this is Nancy Newman, who is, very well respected in this community. She says, yeah, absolutely. They have we just don't have scales for that. It's not visible on papilledema, so we can't grade it with an objective. And I asked them, do you have patient-reported visual scales that we could use? And she says, yeah, we do. So hopefully this year we're going to start playing around with some of the patient-reported visual scales. It's not perfect, but since we don't have any objective measures, subjective validated measures may be a benefit. In terms of veins, venous stenting, this is an area that where our hope is this year we'll be publishing something with all of our centers. The old Hopkins data that Larry was part of, Dr. Constantino and Lowe's data from Northwell are experienced now at Queens. The good news is, and I think Peter may join this, but one of the very tantalizing pieces that we've got right now is we've done about, very small number, but 5 without taking out the styloid and 5 without touching C1 and 5 jugular decompressions, intentionally taking out parts of C1. And the preliminary data is, as you would expect, substantially improved jugular expansion after the C1 version. So we have an MD PhD student currently quantifying those numbers. And so this should be an opening shot in terms of how do we optimize anterior approach, not posterior approach surgery for this. And obviously there's a lot more to learn. So that's comment 1. Comment 2, stenting for C1 is terrible. I would tell all my friends, if there's a bone, leave it alone. That sounds like a saying. Maybe we can make that an aphorism. But there is, frankly, we have a paper that should be coming out at half year called An Atlas of Jugular Venous Stenosis. A bunch of the people on this call will be co-authors, but we record maybe the 9 or 10 features that we've seen occluding or compromising the jugular venous flow. And this is important because for those operators that are only treating one element of it, who are unaware or intentionally unaware of those other elements, frankly, I think eventually it becomes shady if all you want to do is ignore the anatomy that's there. So to that end, the bony decompressions we think is absolutely first line for if that's the most significant narrowing. However, there's a substantial number of patients that occlude or stenose or increase venous pressure when they move their head around. And most of these are muscular compressions or ligamentous compressions. So Dr. Cha, I'm going to cede the mic. I think she just joined. So she has experience in this space. Our groups, Kyle and mine, we are putting stents in a limited basis for this. It is, we're learning a lot. And one of the other features of this atlas is going to be mapping out where the cranial nerves cross the jugular vein. And most of them cross the jugular vein somewhere. So we've seen multiple cranial nerve palsies, most of them transient 1 to 2 months. We recently had a brachial plexopathy with a lower placed jugular vein. So the patients, at least currently, claiming headaches and brain fog are substantially better. However, there is a brachial plexus injury. So we have a lot to learn. The stenting is as experimental in a sense as the surgeries. And so we're going to have to teach ourselves new danger zones, new sizing characteristics, new ways of doing this. And it's going to be a process. I don't want to terrify the patients one way or the other, but we're all learning with you. So the stents are just as much an issue. The jugular stents also are painful. Almost everybody complains about stretching and pain for about a month. So it is by no means a get out of jail free card. Yoonhee, 안녕하세요.
Hi, everyone. I'm sorry I'm late. I know I have some patients of mine that are on this webinar, and you know that my son just had a violin recital that I just got back from. So first of all, thank you for organizing this and for Dr. Huey for inviting me to this group. So I'm a neurotologist, so I come at this field from patients who have dizziness, predominantly. I'm not a tinnitus specialist, but you can imagine that a lot of my patients also have tinnitus. So I came at this field a little bit sideways, but I think maybe the perspective that I can also bring here is that I got interested in venous compression disorders because I had seen a lot of patients with thoracic outlet syndrome. And we were doing decompression of thoracic outlet, with verb resections, and the patient's headaches were getting better. And if you kind of do a little bit of a deep dive into thoracic outlet literature, you'll see that besides the arm symptoms, everyone's getting surgery for the arm symptoms, but the number 2 and the number 3 symptoms that get better are headache and dizziness. And so my interest in this area, certainly, 4 years ago, I didn't even know what Eagle syndrome was. But now the way that we look at this syndrome is looking at the extracranial venous system as a massively parallel system, and with compressions that happen in multiple areas in tandem and bilateral, and to understand why people do or do not get better after certain interventions. I think you have to actually look at the entire system, right? So, we're very familiar with the compression at C1 or C2. There's actually a second point that is commonly compressed, which is under the muscles in the neck. And that's kind of like the hidden area where you get jugular vein compression. It's under the omohyoid sternocleidomastoid complex. And typically when you have this compression, you'll get ipsilateral head turned triggered symptoms. So you'll have vertigo or you'll have tinnitus. And this compression almost always happens in the context of thoracic outlet syndrome. And so we always look at the subclavian vein, the internal jugular vein with head rotation, all at the same time. And in some patients, so, I've had the experience of having patients get styloidectomy first and then taking care of the muscles, and then patients go the other way where they take care of the muscle and then take care of the C1 compression. And sort of the big picture story, I think, with these multifocal compressions, and certainly I've had patients who've had basically 6 compressions, right? So they have compressions at C1 bilaterally, under the SCM bilaterally, at the thoracic outlet bilaterally, and sometimes they have pectoralis minor, compressions bilaterally. Is that each sort of decompression may be necessary but not sufficient. And so if you have a decompression, but the patient's not totally better, I mean, that's kind of the time to look at where else are they, having this compression. And, hopefully, you get a little bit of improvement or noticeable improvement with each decompression that you do. But especially if you start seeing like surgery failures and things like that, I mean, I think it's important to look at where else could they be having trouble, because when you do venograms on these patients, everyone just has like a different shunting pattern. Like some people, when they're compressed, they shunt straight back up. I mean, because the blood is flowing down a pressure gradient, and that pressure gradient, may favor going straight back up the skull base or straight back up the sagittal sinus or around the brainstem or into the spinal cord or into the muscle. That's what makes these syndromes so complex. And the patients have so many symptoms because almost like by nature, because this is such a forgiving system that's very good at forming collateral veins, very good at finding a way around the problem, is that patients are almost like super complicated by the time that they present. So the main thing that we really struggle with is if you're going to decompress a patient, where do you go first, right? So we go with what our resources are. We try to treat thoracic outlet syndrome, and we started a program treating the muscles in the neck. So I always start with physical therapy. That can actually, and you don't let the physical therapist figure out what to do. You have to tell them what to work on, because in general, without sort of knowing this background and not without knowing this anatomy, generally, people, our ancillary staff will work on where it hurts, but that's not where the problem is. So it's not obvious to people that you have to work on the thoracic outlet when you're having a headache, for example. And this also goes to working with our PM&R colleagues, right? So they want to inject where the patient's having pain, but that's not where the problem is. So we started this sort of non-invasive sort of protocol, the non-invasive meaning not scalpels or stents, starting with a good PT regimen. And then we started doing Botox to some muscles in the neck and also the thoracic outlet. So we generally inject the sternocleidomastoid and the anterior scalene muscle. And then it's a real, toss-up between, is their thoracic outlet more severe, or is this SCM entrapment of the IJ more severe? We actually get really, really good symptom improvement with opening up the thoracic outlet. And probably because this is kind of a parallel system, you don't have to open up every single vessel, to get, if you're very on the far end of this like pressure volume curve, you don't necessarily have to get all the way down to, 50%. If you just kind of get yourself down a little bit, sometimes that's where, like you get a lot of movement. So we're always trying to find like the 80-20, point for patients. We do have patients who have to have 4 or 6 decompressions. But that's our struggle now is where can patients get the most bang for their buck? And a lot of patients do still have to get decompressed at C1. So I'm grateful for all the surgeons on this call who do the C1 compressions. I've seen a lot of them go very badly when the surgeons do not know what they're doing. They're not comfortable in the skull base. They're not comfortable getting really close to the vein. They're not comfortable, cutting that styloid back far enough. So what they'll do is they'll cut the styloid back to like a quote normal length, but it's still below the point of compression. So I do hope, we're like at the front end of this story we have 2 major medical centers in Minnesota, and I still send my styloidectomy patients to other states. So that's kind of my background. I'm sorry to kind of come right at the tail end, but I'm happy to clarify any of my position on that.
No need to apologize. Just thank you so much for joining after the recital. I really appreciate that. We had some clarifying questions in the audience from the audience and some follow-ups. Can you talk about what you mean about taking care of the muscles, and then like where you're finding compressions and what muscles are a major culprit in this?
Yeah, so I started working on this sort of injection protocol around 2020, and I actually worked with a wonderful PM&R doc. And eventually I was sending so many patients to him that I was like, can you teach me how to do this so I can just do it myself? Because I was like really overloading his patients. And so we actually worked on trying to find what are the minimum number of muscles that you have to inject to get, again, the most bang for your buck. Because of course, these the medicine that we're injecting are neurotoxins. So the one that everyone knows about is Botox, right? But there's other products, right? Like Xeomin and Dysport, for example, that can also be used. So the minimum muscles that we inject are the sternocleidomastoid muscle and the anterior scalene muscle. And the reason why these are like the core kind of muscles you want to inject are that the anterior scalene muscle is part of the thoracic outlet, right? And so if you relax that muscle, it'll help drop that first rib and you'll help free up the subclavian vein. If there's a lot of thoracic outlet symptoms, I'll sometimes also add some medicine to the middle scalene and also to the pectoralis minor muscle, because you can actually get a what's called a double crush syndrome, where you have compression of the neurovascular bundle going to the arm, both at the thoracic outlet, but also under the pectoralis minor tendon. But like kind of where we start though is that anterior scalene muscle to free up the subclavian vein. And the second is the sternocleidomastoid muscle to free up the internal jugular vein. So now, why do we inject that sternocleidomastoid muscle, and where do we inject it, right? Because the SCM actually has two bellies, right? Because one part of it goes to the sternum and the other one goes to the clavicle. So a big part of the story seems to be a little muscle called the omohyoid muscle that sits right over the internal jugular vein. Now that muscle is actually fused with the carotid sheath, and it is so it's actually like just sitting right over the internal jugular vein. It's a sort of like variable size in different people. So right now I would say like I'm not that comfortable injecting the omohyoid muscle, but I think that we could probably develop a way to do this safely, because in some people like it is kind of a big muscle. I mean, it is, it's a reasonable target. So I inject the sternocleidomastoid muscle at the level of the omohyoid, where it is crossing the internal jugular vein. Unfortunately, that's also where the SCM is like kind of big, right? So you always, safety first for everything, right? And so I don't know if some of the, medicine like diffuses to the omohyoid, but, it's sort of like a 2-for-1, in some sense. So, but the cool thing about this sort of two muscle protocol is that the internal jugular vein in some people is actually sandwiched between the sternocleidomastoid and the anterior scalene. So it's the SCM in the front and the anterior scalene from the back. So you get sort of a 2-for-1 by taking care of that anterior scalene muscle. So yeah, so like our protocol is basically we just inject two muscles on each side, so 4 muscles, and then if they have a lot of TOS symptoms, then we inject a little more to take care of the TOS part.
So
And simply,
Dr.
sorry, go ahead.
It's really nice to meet you. I've admired your work from a distance. Having said that, I've wondered for quite some time, given that the ansa cervicalis feeds the omohyoid and components of some of the other strap muscles, if lysing that nerve might result in substantial relaxation lower in the neck. And that can be done from the same approach as the approach to the C1, which is an incision up here, because you simply go down to the hypoglossal and you can lyse that nerve. Any thoughts?
Yeah, well, it's so what we try to go for is, being as sort of minimal as as possible, do as what's the least amount that we can do to get the most benefit. So in some patients once we get to like 80% benefit, we're like we're done, right? Like, because it's just every more that you do, your benefit to risk ratio, it changes. The surgeon that I work with, Joe Karam, who's going to be at the Honolulu meeting, this whole process only works because he's an amazing surgeon. From what he says, like that surgery is not that difficult from, I mean, so you sort of look at, what's your, what's the investment, right? So what he does, is he goes into this anterior approach, just medial to the SCM, and he just cuts that omohyoid, so it's the upper, so the omohyoid has two bellies. So it's the upper belly that he's excising, and then he just shaves a little bit of the SCM down to just kind of debulk it. We never talked about any kind of nerve surgery or nerve. I don't know what that entails, if that's maybe less invasive or at all, or
if you've been successful with the Botox and proven that that's the target, and the Botox needs to be repeated every 3 months or so, then the question is a permanent surgical intervention. And if you target the omohyoid, which you can, and it's intimately adherent to the anterior surface of the jugular vein, you can certainly target it, but there's other strap muscles that cross that jugular vein as well. And by targeting the ansa cervicalis, which is a very small nerve and doesn't have much impact if it's transected functionally, it could represent, without an incision in the neck down here, a more aesthetically appropriate and a more comprehensive approach to the strap muscles than just a lysis of the omohyoid anterior belly. But we're getting pretty technical here. We should talk offline.
Yeah. No, I think that would be a great thing to discuss, at the meeting in person also, because we've gone back and forth on this too. It's like, is there some way to do a minimally invasive procedure, where, I mean, like the patients have not cared so, I mean, when they feel better, they're less worried about the scar, but yeah, I mean, is
It's a
there,
real scar in the front of the neck and it's
yeah,
noticeable.
yeah, it's right. So yeah, but it would be wonderful if we could, make it a same day procedure, right? Even, but yeah, no, I think we just have to, pay attention to everyone's outcomes. And for us, so we've used the Botox both diagnostically and therapeutically, right? Some patients are just not good surgical, candidates. But we can't have people getting Botox forever, because you're just from a resource standpoint, it's 4 appointments, for each patient every year. So it can be really hard to get into our clinic, but responding to Botox is actually very predictive of responding to this SCM, shave surgery. Not responding to Botox, people do still respond to surgery. It's not as good though. And maybe it is because there are other muscles that need to be addressed, right? And so I think that would be a really interesting, important thing to talk about, is maybe those patients would be better off getting like a denervation procedure.
I'm going to make one quick comment. I don't know how many of you guys have run into these patients. Clearly, Uni's running into some of these. We've had a number of, they're generally males, athletes with big muscular necks, and they have muscular compression, typically lower jugular, provocative, occlude on head tilt or head turn. And so these patients, I have not known what to do with. We've had a couple 18-year-olds, 17-year-olds, 14-year-olds, and no parent in their right mind is allowing you to put a stent in or cut out their muscles unless, well, we're not there yet. So I think it's a very good group of patients to just pay attention to. They're there. They're even harder to find in a sense because I think there's a more stigma with the males. I'm dizzy. And you're a 14-year-old who's dizzy. How do you find care? So I touch these patients with a velvet glove, and I've had friends refer friends with kids with this, and I'm like, they're 14, they're a tennis champion, and they can't play tennis right anymore. What do we do with them? So I look forward to having a more stable answer. And if it is denervation, wow, that's something to be said. None of the parents want a large scar on a 14-year-old's neck.
All right, so I know that we're over time, just to acknowledge that, and I appreciate folks still being here. If anyone does have to leave, I totally understand. We have a few more questions, and I just want to start with a follow-up for you, Dr. Cha, and then for anyone who wants to add, because we've been talking about venous congestion, but like also in relation to CCI, given the EDS patient population we're focusing on. What are the concerns for Botox with with CCI, and are there certain muscles that should be avoided for that?
So good question, because I would say about a quarter of my patients that I see with venous congestion problems do have hypermobility problems. I mean, patients, get to this syndrome through different ways, right? So, I mean, it's a lot of hypermobility in the younger patients, and then there's a lot of I would just call like wear and tear, and just toughness on your musculoskeletal system in the older patients. So I would say in my so I have sort of a standard protocol, for how much to inject into each muscle. We are generally fairly conservative with the amount of neurotoxin that we use in our clinics. So I'll use like 15 units, per muscle. I know some places might, start with like 25 or 30 units. I've even seen like some docs put like 50 or 100 units into a sternocleidomastoid muscle. That's just not where we are, right? So in general, so I'll start with 15 units per muscle, so 60 all around. And with that dose, the rate of neck weakness, because that's the main thing that we're really worried about is head flexion weakness, because the scalene and the SCM are both like head flexors. The rate of neck weakness is somewhere around 3 to 4%. And it gets better. It gets better, with time, just like whether the effect is good or bad with Botox, it gets better. I will say that with my hypermobility patients, like I will start lower at 10 units. Every single one of them is able to get back up. So, we're still able to like get to like a normal dose, like 20 units or 25 units. So I think starting lower, I think it's more for everyone's comfort. Um, but it seems like for some patients, when they get weak, they're just going to get weak. And because the few people who've had the weakness, it's really unclear like why they got weak. And they were actually not even the hypermobility patients. But I think once we get, just gather enough numbers, we can say, okay, we're pretty comfortable kind of starting at the same dose with our hypermobile patients, as everyone else.
Thank you. And Dr. Bolognese, do you want to add anything about Botox in the context of folks having CCI?
No, everything has been covered, so I have nothing to add.
Perfect. Good to know. That definitely helps us in the interest of time. So moving along, let's get into a little bit about abdominal compressions as well, now that we're touching on some stuff outside of the head and neck. So some abdominal venous compressions share symptoms with other EDS comorbidities. For example, May-Thurner syndrome and tethered cord can cause leg pain, while nutcracker syndrome can present with headaches and orthostatic intolerance, which overlaps with, of course, multiple EDS-related issues. How do you determine when to screen for abdominal venous compressions, and how often do these diagnoses appear in patients already diagnosed with CCI, venous congestion, or ICP issues?
So back to quarterback, and I believe Paulos threw the ball at me while in the chat room. I think Eileen and Dr. Kaufman will probably be the best to start with this. And after those two have commented, I'll have some comments because I've been building the intersection on the West Coast for these two domains.
Yeah, I'll jump in. All right. So it's a really good question. Full disclosure, as far as I'm concerned, I'm still on a steep learning curve about this. It is somewhat new to me over the last couple of years, I guess. But what I have learned is that the more I look, the more I find pelvic and abdominal venous compression syndromes. It's actually pretty staggering, to the point where now if I have any patient with relatively treatment-resistant POTS, I'm going to refer them for evaluation. And I refer a lot to a group in Denver, and I've had a conversation with Dr. Brooke Spencer there recently, who basically asked me how come every single patient I send has been positive and has a iliac vein stenosis. And I think it's because they're a very highly selected population. They all have connective tissue disorder. They all have POTS. They're all totally disabled or very disabled by the POTS. And I think it's a condition that we need to look for sooner rather than later. And where I might have waited 6 months, now I'm doing it sometimes even in the first visit, making a referral if I'm suspicious enough. Ellie?
Yeah, I mean, I agree. The more you look, the more you find, and a lot of the symptoms do seem to correlate to compression syndromes of the abdomen and pelvis. I have a lower threshold now to just order a mesenteric ultrasound looking for mals. I'll order CTAs of the abdomen and pelvis just because symptoms of that part of the body, which I don't understand all as well as I understand more of the nervous system. I just have a low threshold to order that kind of imaging to start the workup looking for compression syndromes. Having said that, I too don't I don't really understand. There's nothing I can do about them. So I end up just referring them. So I've started to sort of change up how I do it with it, which is just place the referral. And then the vascular surgeon usually knows the appropriate protocols for even the imaging, which usually I've ordered it incorrectly. So so I do think that it's an important part of the EDS workup because it does seem to, again, the more you look, the more you find, and we find this fairly regularly, and it does contribute to symptoms. So I think it's an important piece of the puzzle for EDS patients.
I just want to add something that's probably obvious to most of us, and I'm sure obvious or becoming obvious to anyone listening. Our patients with these complex illnesses don't have one problem ever. They never just have one problem. They have a whole multi-system connected pattern of problems with dots that are connected to dots. And on top of that, dot A causes trouble with dot B, which makes C get worse, which suddenly makes A get worse. And I hope if there are physicians watching, don't just think of one problem. You need to look at the whole patient and listen to what that patient tells you and realize that, especially if it's a connective tissue disorder patient, that's their whole body, that connective tissue. And if you think about it, you're going to find things that you might not have thought of before. It's kind of the opposite of build it and they will come, okay? The patient has all these risks and they need to be considered in the full context of that patient's history.
Yeah, and I think it's important because some of the vascular surgeons have told me that when they correct either the MALS or the Nutcracker, the May-Turner, and so on, patients will report improvement in their autonomic nervous system symptoms. And I think that's important because, I always take issue with the idea that everyone is diagnosed with POTS because the autonomic nervous system is so complex that it's almost offensive that everyone just has POTS. So I think that showing that the fact that when you intervene on one of these abdominal pelvic compression syndromes and the POTS symptoms improve, that is just more reason to further interrogate their autonomic nervous system to sort of find what more lies underneath the POTS diagnosis, which is what I very commonly say. So I think it is an important piece of their workup for sure.
All right, before I give my 2 bits, anybody else want to add to this? Okay, I'm going to add my 2 bits. I completely agree that EDS is systemic, and I really do think that it's very, very important to realize that most likely all of you that EDS probably have whole body. If you're in this chamber, you probably have whole body venous disease. You just are not good at partitioning stress. And I'm not talking about your psychologically, I'm talking about fluids and pressure in your system. So I think that if we look everywhere, we'll probably find something. The problem is, how do you choose what to treat? The current method that I'm doing is if you're EDS and you see me and your worst symptom is head, brain fog, blah, 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 I'll look here first. If you have tight and obvious targets, we'll run with this. If you don't have tight, obvious targets, I go down because this doesn't look so bad. Now, a little bit about physiology, and Walter Schievink, I really wish you were here. He'll be presenting on some azygous venous abnormalities that contribute to brain fog, etc. The bottom line is every major venous conduit in your body can screw you. And so the reason why is there's a valveless system, a trough that goes from your brain to your azygous and hemiazygous systems, which then connects with the rest of you. And so if you have venous congestion in any part of your body, it can use the trough to kill your brain. And my view is that the autonomic problem, and this is, of course, unsubstantiated, do not quote me. You probably will quote me and then I'll get in trouble with all my POTS friends. But if you have venous congestion surrounding your autonomic ganglia, all your autonomic ganglia will be pissed. And so that's what the mechanism, I think, that all of these diseases can result in dysautonomia, whether it's through vagal nerve irritation or the autonomic ganglia. That whole trough that connects your brain to your sacrum, that's fair game. That's a sewage tank. And if anything gets in there, it can piss off the rest of your system.
I just have to add one comment. I so totally agree with you. That is such a great description. When I'm trying to explain this stuff to patients, I'm always using the plumbing analogy. And so your sewage system fits in perfectly with that, unfortunately. This is plumbing, and the plumbing is screwed up, but it's all connected. So, as Eileen is also alluding, if somebody has a compression in their pelvis, it's the patient, we need to understand and explain that just because it's all the way down in the lower end of their body, it's going to affect their brain because it's going to affect blood return to the heart and cardiac output and decrease perfusion to the brain and then decrease perfusion to the muscles. And it's all connected. And it really is a plumbing issue.
I'm going to throw out one other thing that some of you may have already seen. Karthik Arcot in New York somehow decided to start treating brachiocephalic venous compressions, which I agree with. He just went way faster than I did. He's already done 60. I'm going to look at his data. I'm very curious how it looks. We've treated 3. I sent one to Johns Hopkins for surgical decompression, and they went from bi-monthly visits to the ER for headaches, and they no longer go to the ER for headaches and brain fog. So at least in that N of 1, they're better. We have 2 others that one is about to be treated next week, and one was treated without very good results. I'm going to see what Dr. Arcot's results look like, and we're going to look at starting a trial for brachiocephalic venous decompression because these are the conduits: azygos, brachiocephalic, jugulars, intracranial. You're going to see some deep venous work from us soon. And then, of course, the warning. In the abdomen and vein, none of us are experts in this room, but I will tell you, I have seen some of the treatments of pelvic congestion, and some of them are embolization of collaterals. I don't know enough to tell you that's a bad idea, but my instinct is that's a bad idea. The collaterals are a compensation system because you've lost something. So this is akin to being in New York and Lincoln Tunnel is down. So to treat Lincoln Tunnel, you'll close off one of the bridges between Brooklyn and something to treat the traffic congestion across the Holland Tunnel. That's a bad idea. Now, we don't know for sure, but I would say that if you talk to some of the people that are very sensitive in this space, Brooke Spencer being one, she thinks this is a very bad idea as well, because what you're doing is isolating venous networks that are trying to drain your body. So I would just caution everybody here, be careful, just as you're careful getting referred to somebody to do your IJV decompression. Dr. Constantino does amazing work. Be careful who you go to for body work as well. There's a lot of variability, and I think we need to be very careful step by step.
Yeah, the first time I saw a similar scenario was years ago, like 22, 23 years ago. We did not know about all the nutcracker and etc. But we saw a lot of our patients were having varicosities around the ovaries, and they were going for treatment, and then they were worse afterwards. So that was kind of an early shot for the same concept that you were presenting.
All right, I want to make sure we just get to at least 1 or 2 of the questions that folks had about CSF leaks. So are EDS patients with a history of recurrent spontaneous CSF leaks resulting from underlying high pressure more likely to have intracranial hypertension without papilledema due to their fragile duras leading to a leak before pressure gets high enough to affect the optic nerves?
I'll let Eileen go if she wants. Although, did Eileen run away? Oh, there she is. So I'm one of the few people that treats low, high, and ampi pressure. So my comment is EDS, first of all, you guys never get to qualify for IIH by traditional measures. So this is a trick question. The reality is, even though you never get to those high pressures, you have the IIH phenotype, you have the danger of leaking because you have weak tissues. But as we've also learned, and I have a publication with, I think with Dr. Shivink on this, the presence of jugular venous compression on patients with spontaneous CSF leaks is also high. So in fact, you guys have two reasons to CSF leak. You're very vulnerable to getting IIH spectrum venous congestion, and you have softer tissues. So I think leaking for you guys is common, too common. If you have recurrent leaks, my suggestion is as follows. If you get better after a leak treatment and you're happy, live with it. Don't go looking for trouble. But if you're having recurrent leaks, it's very likely that somewhere in your system you have venous congestion, whether it's abdomen, pelvis, head, or neck. So if your CSF leaks are out of control and you're flying to Duke, you're flying to Mayo, you're flying to Cedars-Sinai every year, you probably should be looking for a venous abnormality. That's my view. And yes, the problem is your numbers don't fit the textbooks. So in a sense, your phenotype defines how we see you rather than your numbers.
Yeah, in that case, we have a roller coaster phenomenon, which the baseline is high pressure, and the repeated leaks are just pathologic ways that the body compensates for it, because under normal circumstances with a normal dura, the pressure would stay high. But with the dura so stretchable and the little ballooning around the origin of the nerve roots, those pop, the pressure goes low, pressure feels better, then worse, and then better again, and then drifts up to the baseline, which is high pressure to begin with.
I think we really need an update, of this concept of like what is normal pressure, because, we have this kind of artificial number of 25 centimeters of water and trying to, kind of convince people around us sometimes is that everyone has like their own kind of normal, like whatever their set point is that works for them, right? And so what's really now when I have, patients do lumbar punctures, what really matters to me is, well, how did you feel, right? After, getting some of that fluid off, regardless of whatever your initial pressure was. Now, patients can have really, really severe symptoms of head pressure. And I have found that that does not correlate with their CSF pressure at all. And their CSF pressure with these extracranial vein compression disorders, like the numbers will be sort of on the high side of normal. It's what I call like sort of the 18s, the 20s, the 22. I think the highest number I've ever seen was maybe like 29, which is not so far out of, what we understand to be like the normal variation, right? So I think, a lot of what is perceived, to be pressure is not from this stretching of the dura and the pressure is high inside. It's probably just like tissue pressure, right? Just from like muscle compression or irritation of the nerves or, et cetera. And it can be bad enough that people can't lie down, right? So I probably have a dozen patients who sleep in a chair, right? Because they have such severe pressure from lying down. And then it gets really complicated, based on where venous flow is supposed to go when you're upright versus lying down. But I definitely think that this idea of normal pressure, CSF pressure has to be updated. I will say that regardless of whatever is the main driver, of patient symptoms, we tend to have a lot of CSF, like post-dural puncture headaches and leaks in patients. And so whether they are already vulnerable to spontaneous leaks or not, our post-dural puncture, from LPs is like almost 30%. And if you look at the institutional rate of CSF leaks, which is all comers, people getting LPs for like multiple sclerosis workup or Guillain-Barré workups, it's like 2%, right? And that's what's in the literature. So our institution average is about what's in the literature. So there is like a combination of factors here. There probably is a little bit of like connective tissue weakness, and maybe that number of 18 or 20 or 22 is actually high for that person. So anyway,
a couple of things. Number one is there are not so many people who actually do direct measurements. So there is not a lot of centers who measure. They just treat the patient under the assumption that the clinical presentation is reflecting a high or a low pressure. Number two is the threshold for papilledema is 26. And like we have seen repeatedly over and over, the majority of our patients with EDS who are symptomatic for increasing intracranial pressure symptoms who respond well to either shunting or therapeutic lumbar puncture or decompression of the jugular. All these patients live between the values of 20 and 24. So that creates a confusion. You go to the patient goes to a neurologist, not like Dr. Ruhoy, but a standard neurologist. Neurologist says this patient doesn't have high intracranial pressure because it doesn't have papilledema. While this patient live in the gray zone between the normal pressure and the pressure at which papilledema would appear.
So I had a patient, I put on methazolamide, which is a carbonic anhydrase inhibitor, and went to another institution and they did a lumbar puncture while she was on the methazolamide. They didn't know what it was. I mean, so her pressure was 4. She was actually very happy at a pressure of 4. So, this is the difficulty, because if someone, measured her and she was like an 11 or 12, we would have thought that's totally normal. But for her, that's not where her brain is happy at. So
I'm going to give 2 comments on this. Anybody who's watching Stephanie Lenk's work or followed the travesty of Q-collar, very, very important stuff. One, Q-collar, that's much more exciting. Some general practitioner, I shouldn't insult him, he's probably very, very smart, but had the idea, to borrow from neurosurgery, jugular compression to increase tergal pressure of the brain and thereby expand its size and resist concussion when people get knocked about on the football field. They proved that the brain swells. They can prove that when you put on the collar, your brain gets swollen. And they got it approved as a Class 2 FDA approved device, and nobody wears it anymore because, of course, it makes you miserable. We are actually using this for some experiments. On the other side is laboratory experiments from Dr. Please, Peter, go ahead.
So my son is going to be going on. He's going to be a quarterback in a D1 school. And I got introduced to the Q collar a number of years ago. And my son tried to wear it and it made him so sick that he's like, I'd rather get a concussion. I think it's better. And so we every so often, for patients who are equivocal, we'll have them buy a Q collar to see what it does to their head. And at the end of the day, the vast majority who put that on, it makes their symptoms worse. I can't believe that thing actually got approved to be sold and used in general.
All you have to do is say concussion. Funding comes in, right? NFL. Yep. On the flip side of this is Stephanie Lenk's work. She's ligating IJVs in animals and has shown that the brain swells after IJV ligation. My point of this is to say that we focus so much on the CSF pressure, and really it's secondary to what's happening in the veins, brain swelling, pressing on the CSF, reducing CSF absorption, probably other factors that I'm unaware of. But I just put this out there for you all as patients. Don't let your practitioner focus you on your CSF. It's really just a piece of your drainage. It's a piece, it's in contact with your brain. And so we have a lot of work to do, but the point is just that these are deeply, deeply interrelated systems. And I'm sorry for cutting you off, Peter. Please take it away. Oh, if you guys are interested, I'm sure you guys are getting ready to publish it. I'll include you on some of our Q-collar and Q-collar adjacent work. Please feel free to collaborate. We're very excited.
That'd be great.
All right, I have a couple more.
My son's going to pass.
All right, so I have a couple more questions. One more for you, Dr. Cha, and anyone else can add anything if they would like to. What would you say is the gold standard in terms of diagnostics for thoracic outlet syndrome for folks who may be newer to considering that?
Well, so this is a hairy area, right? Because, thoracic outlet syndrome has been, recognized for decades, but the diagnostic criteria for it only came out in about 2016, and it was really only really defined for neurogenic symptoms. And what we know is that, when people have neurogenic symptoms, they very frequently have venous compression at the same time, but there is no like set criteria for venous thoracic outlet syndrome. The same sort of, paper that came out with this neurogenic TOS criteria, which, by the way, like has no diagnostic test even of itself, right? It's all like a clinical test and response to treatment, and the kind of triggered arm symptoms, et cetera. So the venous story is really, really difficult. And so I think one thing that has sort of unfortunately happened is that a lot of the vascular surgeons will not diagnose venous thoracic outlet syndrome until there's a DVT. And for a lot of us, that is too late. That is way, way too late. Once you have a DVT, I mean, and you start having like valve incompetence, and I mean, it's a long ways. So we diagnose venous thoracic outlet syndrome with dynamic ultrasound, which is looking at the flow in the subclavian vein, with arm abduction. And sometimes we have the patients also get an actual catheter venogram. Now, the thing though is, there is a fair amount of these compressions in the normal population. And this is why we need a lot of research in this area, because normal healthy people with no symptoms, you have to pay them, you have to pay for their studies. There's no insurance to pay for their studies, but we do need to have a population of like healthy people. Now, there have been studies on thoracic outlet and ultrasound, okay, but they focus on arm symptoms, okay, but especially venous thoracic outlet syndrome can present with headaches and tinnitus and vertigo, right? And so those initial, and this is sort of the problem of like slicing and dicing the body into these parts and being siloed and not realizing that everything is connected, is that, those TOS patients were not screened for whether they had migraine, right? Or whether they had tinnitus, or whether they had, dizziness. So in some ways we have to kind of go back a little bit, be a little bit more comprehensive, about, who we're really, considering to be normal. So, but the short answer to the question is, I first look for neurogenic symptoms, with an upper limb, tension test to see if, if there's any like triggered, arm numbness or paresthesias. We do a dynamic ultrasound, and then and oftentimes like the story is clear enough to take the next step. But if not, then we do a catheter venography.
So I've been sent a lot of these patients lately. So Yunhee, I'll have a new trick for you. So because I have so many patients that I'm in their veins, the ones that have thoracic outlet syndrome symptoms, I've been sticking a catheter into their brachial vein, injecting it neutral, up, and then provocative. And the pressure will go up as high as 89 millimeters of mercury if they occlude. And you see this clear occlusion. The best part is the venous blood goes up into the neck and then into the azygos and hemiazygos systems in some of these patients. So I suspect that's why they end up with headaches, because they're basically using that gutter. I haven't written this, but maybe I should. It has literally not been on my mind to write. But similarly, I have patients that, I'm there, I go and test them, and nothing, no occlusion, no increase in pressure. So I suspect that we will be eventually able to use these types of techniques to find patients that have, especially the ones that provoke neurologic symptoms, this sort of pathway.
Yeah, that's one. So we just got a paper published last fall on treating migraine with TOS decompression, and it took 13 submissions to get this, because finding people who can even like review this kind of paper that's the midpoint of vascular and like no one exists, right? So but it's a real thing, and different people in different disciplines have to work together. So just to actually follow up, because this is I should have brought this point up too, is that we also do diagnostic blocks too. I mean, sometimes we'll do a lidocaine block. And when we have a little bit of leeway, we might actually even do Botox, and see if the arm symptoms, get better with Botoxing the anterior middle scalene muscles. So typically we'll like do that if it's a little bit unclear, and we just need like that extra level of evidence. So yeah.
All right, if no one else has anything to add on that, I have one final question before I open the floor a little bit. So access to specialized physicians for diagnosing and treating these conditions is limited, especially outside the US. How can we encourage more doctors to enter this field? Do you have any advice on how patients can help educate and engage their local physicians in learning more about these conditions?
That's why we've started the Venous Summit. We're going to try to do one in Europe in the next couple of years when Stephanie Lenk is finished with maternity leave. I'm working on bringing this to Asia next year for an annual meeting. I've started lecturing in the Asia circuit on these topics. So that's how we do it. It takes a long time, but we have to keep teaching. There's not enough of us right now to treat all of you.
Yeah.
And the good thing is that the times have changed, and there is less skepticism. There is more focus. There are more and more people coming in. Usually, they think, the motto that I say is, once you see it, you cannot unsee it. And that's why we're all here.
Yeah, and I think what we need to do is to help other physicians have a little bit of success in treating patients, because that can be kind of addictive, right? I mean, the people who go into medicine, like, they were competitive and top students and used to being successful, and now we're sort of asking them to think about things in a way that they didn't learn. Like, this is not part of their foundation of like how the body works, right? When they went to med school and their training. And so so I've talked to some other physicians who do injections at other institutes in the United States, unfortunately not in Europe or Australia or Asia yet. But but I think, once they get a little taste of like being able to turn someone's life around, and sometimes it's not like a really major thing. It's like, it's about uh, getting the patient into the right physical therapy program, right? Or getting them into the right cervical spine alignment program, or, moving on to, doing injections by collaborating with some of their PM&R colleagues, right? I mean, so we have to also like give people the tools to be successful, get the right paradigm, into their heads. I will tell you that, of the lectures that I have given in this topic, there has never been a time where someone had said, this idea is ridiculous. Those usually kind of happen in papers and grant reviews. Well, they say, well, this idea is so great. Why have I never heard of it before? But generally people are kind of like, they're actually starved to hear of an explanation for why patients have such severe, complex symptoms. And so I think the thirst is there, and I'm grateful for this group, also, and we'll eventually get there. Ideas become viral if they are, they resonate with people, and also if you help them to do their jobs better.
Thank you so much. Does anyone else have anything they want to add for that one? All right, so my final question is just a more broad kind of, is there anything that you would like to share with the audience that you feel has not been raised yet by the questions? Or is there even like anything that you would like to ask each other as physicians on this panel?
Could I ask a question of the surgeons? Because we've had some really a lot of pushback from ENT of doing stylotectomies. And even patients who, we get them the venogram, it's positive, it's clear the IJ is compressed by the styloids, and the, vascular surgery and ENT, they're like, oh, we sacrifice the IJ all the time and the patient is fine, or, this is really, common, or etc. So, and I've had enough patients now over several years that they've done like life-changing opening up their IJs, but what do you say to those surgeons? Because I mean, I run up against it, and probably patients run up against that too. So
Well, if you don't consider it a possible etiology for the symptoms, then you'll never be open enough to look at the symptoms and the data and then contemplate that this actually is a real thing. And that's what leads patients to be gaslit. It's simply the end point of that process where the surgeon who's now being approached to try and help with something that has actually been diagnosed is resistant to do so because it doesn't fit with their pre-existing paradigm. I think that the only thing that can solve that is by working together to prove that these things are real. And to prove they're real, we need data. And to have data, we not only need to take care of patients, but we need to capture the results from that in a methodical fashion. And I congratulate particularly Dr. Yui in putting together what is essentially a group of people that are going to hopefully do that over a period of time. Nonetheless, we have patients looking for care now. And when I first was approached to provide this access and these approaches, I wasn't sure about it. But as time went on and you talk to enough patients and you give them the benefit of the doubt that they're telling you exactly what they're going through on a personal level, and you hear the story over and over and over again enough times, you begin to realize there's a physiologic basis for this. And when you then treat these patients and you see a success, you realize that the targets that we're selecting are the physiologic basis for these symptoms. One caveat, we don't make everybody better. So there's clearly stuff we don't yet know, and that we also need to figure out. But I don't know how to fix the ENT and others who don't want to operate. They need to open their minds.
Now, for the ENT community, obviously they're comfortable with what they know, and until they have, evidence, good scientific papers telling her that there is something more to it, they're going to stick with what they know.
but is
I
it
came from a
true?
different direction. Before I started doing styloidectomies, there was only one guy in one place who had done a small amount of styloidectomies in the neurosurgical community. So I did it out of desperation because I was sending my styloidectomies out years and years ago. And some of the patients were coming back with problems with their cranial nerves, with tracheostomies, with gastrostomies, with jugular veins being, entered and ligated. And obviously these patients are they're very fragile, and they were coming back with big problems. So at that point, I stopped referring them out to the ENT, and I learned on my own how to do styloidectomies. So I think it's a process. And once you're going to have a core of people like all of us here, we're going to present data. It's just going to be the best way for other these neurosurgeons and ENTs to start doing the same things we're doing on their patients. But you cannot expecting that they're going to see the light just because you tell them.
One additional comment, we use their term ENT. Quite honestly, these jugular vein decompressions shouldn't be done by anybody who's not trained either as a head and neck surgeon, which
No,
is
she was referring to styloidectomies in general.
no, I understand, or some skull base expertise. And I've seen some, just like you, Paolo, some disasters. It seems like a procedure that you can figure out and it's easy to do. But when you're in there, it's very easy to get off target and cause damage to critical structures. So it's not for somebody who's never done this before.
Is it actually true though that you can sacrifice the IJ and be fine? Because that's kind of the answer that I get. It seems like if you're a patient who's sick enough to, you've got cancer or something and your IJ has to be sacrificed, like you're probably not fine in a lot of ways. But I mean, like, how do we answer that? Because like that's kind of the main excuse that I get.
It
Before I
depends
run
if it's
away,
dominant or not, you know.
As
so
a
I have
heavy
to do my next.
surgical, oh, I'm sorry, go ahead. Apologize.
I'm sorry, I have to run and do my next stroke. We have two more strokes. It's raining. Um, by the way, I wish we could spend another day together, Peter and Paolo and Eileen, whoever else is left. This is too much fun.
Yeah.
But I just want to address two things. One, this whole field is too new. Just like you need surgeons that actually know what they're doing, you need diagnosticians that know what you're doing. I've seen referrals for patients like yourselves that say, "Oh, I was read as normal with the vascular cath," and they're not doing a complete job. And then you get this information, you bring it to Dr. Constantino, who's looking at this crappy angiogram, venogram, and what does he do with this? We need thorough evaluations right now because there's so much we don't know. We need surgeons that understand the disease, understand the principles, the philosophy, where are we going with this? And unfortunately, the data is it takes 20 years for a new understanding in medicine to actually become common knowledge. Hopefully we're faster now, but it's still slow. So to try to answer this question from a diagnostician's perspective, I really am trying to train my colleagues to do a thorough venogram because I think it's critical. And I have learned which are the surgeons I trust because I see their results and I see them improve. And that's been very, very exciting to me. I'm sorry for talking so much, but my last question, Julia and Janelle, can you please get an assessment from the attendees when they want the next one? Is it yearly or are we going to do this half year? We can't do it more than twice a year. Take
Yeah,
care.
we'll definitely send a feedback form to check in about frequency. And we're also going to try to broaden this a bit, maybe have one that's a bit more focused on CSF leaks, one a bit more focused on abdominal and thoracic compressions. Yeah.
Fantastic.
Thank you so much.
Thank you.
All right. Thank you, everyone.
Anyone else have any final remarks, anything they want to share or questions?
This wraps up our second webinar on venous congestion. In the coming weeks, we'll send out an email from our venous congestion webinar gmail.com email address to share a copy of the recordings with today's webinar with you. It will also include a transcription and summary. We'll also be sending out a feedback form for attendees to offer input about what worked or didn't work for you about today's webinar and what you'd like to see in our future events. We want to thank Dr. Huey for co-hosting. Thank you to the entire panel for participating, as well as thank you to the webinar organizing committee for helping to make this event happen, including Austin Cliveno, Michael Sullivan, Tiffany Bocchino, and Allie Kelly. From Julia and myself, a big thank you to all of you attending, including the caregivers, physicians, and most of all, the patients. We know that you are not alone, or please know that you are not alone. And we are striving to help all of us get better access to the care we need. Thank you. Yo, are you guys still on here?
Yeah, everyone's still on here. Folks are just leaving.
I'm so sorry.